Okay, we have a couple guest speakers tonight. This is Sarah Cochran. She is the director of the ER. We have Erica Sneed, who is our director of nursing at the hospital, and they're here to talk about stroke.
Yay, everybody's so excited. So, like she said, my name is Sarah. I'm the ER director at the hospital. A lot of y'all, I've recognized your faces. You've probably heard Erica and I spill about stroke before, so this won't be anything new to you. But we wanted to come out tonight and give y'all a little bit of kind of what we do at the hospital whenever a stroke patient does come in, and kind of what y'all can do to help us and the patient whenever a stroke patient is brought to our facility. So a lot of y'all know that we use what's called telemedicine, basically, whenever we have a potential stroke patient that comes in. Depending on how they come into our facility, they're going to get a direct go back, get a head CT, and then they're going to come back, and then we're going to get them on a conference call with the neurologist. And the neurologist is going to watch us do an exam on the patient to determine whether they're having a hemorrhagic or an ischemic stroke, and if they're a candidate for what's called TPA or T in case, which is kind of a new drug that they're starting to use now. So the neurologist watches us do the exam. In the meantime, that head CT, they're looking at it, making sure if there's a bleed, if there's not a bleed. And then the neurologist will give us further direction from there. So some of the things that we have to look for before we get on with the neurologist and do this exam is we have to see what kind of medications the patient takes. So of course, if they're taking blood thinners, if they're taking certain blood pressure medicines, things like that, that's very important for us to know. And that's one of the very first things that they ask us when we get on the phone call with UAMS. So making sure that we have an accurate list of medications. If y'all are like the first on scene, something that would be really helpful is start gathering up medicines, or find somebody in the house that knows what medicines the patient takes or where they are, and help to kind of gather those up and get them ready for EMS whenever they get on scene, because a lot of times they just want to grab those and go. And of course, if it's a stroke patient, time is brains. So they want to get them there as fast as possible. Another thing that's very important is distinguishing a last known well time. And what we call last known well time would be the last time that that patient was seen normal. So if Papa, came in, was feeling fine, laid down for 4 hours, and then he woke up and was having the right-sided drooping, whatever kind of symptoms of a stroke, his last known well time would have been prior to going to sleep. So that would have been 4 hours. Yeah, and that's something that is so hard, and especially when we first started our program, was getting people to understand when the last known well time is, because everybody gets in the rush of things. They want to, get things done quick, fast, and in a hurry. And then you've got one story from the family member, and then you've got, if the patient is still able to speak, the patient might be trying to tell us their side of the story. And we've had it happen a lot of times where there's no way that we could definitively get a last known well time. And that puts them out of the window to be able to get TPA if they are having a CVA, a clot. So that's very, very important, because if we don't have a definitive last known well time, we can't give them that medication, and it could potentially, keep them from having all these comorbidities of having a stroke. So it's very, very important. Yes.
And not all people who have strokes can have certain brain diseases and conditions.
That is correct. Yeah. We have an exclusion criteria. So say what happens is, if I'm working in the emergency department and I hear them get called out for a stroke, I'm already like thinking in my brain, okay, so we've got a packet, and we start looking through the exclusion criteria. We might hear the address, and we might know who the patient is, or, different things. EMS is really good about, giving us as much information as they can prior to getting there. And we're looking through that exclusion criteria because we're already trying to determine, do we need to go directly to CT? Do we need to stop in the room first? There's so many different factors, but yes, there are certain things, conditions that they cannot receive the medication. Something else that I wanted to talk about is TIAs. Who all has heard of a TIA? I'm sure a lot of people have. So one of the big things that UAMS is pushing for us right now is if we have a patient that comes in having a TIA, to go ahead and keep that patient under observation for 24 hours. Because there's been lots of research done that shows that if they have a TIA, that's a precursor for them to have a large stroke. TIA is a trans ischemic attack. So, correct? Yeah. So it's, if you've heard mini stroke, okay, yeah, that's what it is. And a lot of times, like I said, that's a precursor to having a big event to happen. So, and if they're having a TIA, so like if y'all get out on scene and you're taking care of somebody and they're like, you know what, I'm feeling better. You know, my left side of weakness is gone. I don't feel dizzy anymore. I can talk right. I think I'm just going to stay home. You know what? Let's talk about this, kind of give them a little bit of a heads up. Okay, so that might be an indication that you could be having something bigger that's going to happen. So why don't you just go get checked out? And, maybe if EMS comes out, they can help, kind of reiterate that to them. But it's very important to be seen. So if the patients, you go out on a scene, and another thing that is really helpful for us is if they come in by EMS. So if you go out on scene and they decide that they want to come in private vehicle, that really kind of slows everything down. When they come in private vehicle, they don't have an IV started. We don't have any indication. We don't have any knowledge that anything's going on. So Eric and I are taking care of patients private vehicle, and they'll come in and it's like, you're just scrambling because you don't know any prior history of anything. So if you can talk that patient into letting EMS bring them in, it has been shown that it does save time, and it does get them the medication quicker if they are a candidate for it. So what else am I missing?
What we do, like if you guys are in these rural areas, we talked about that, but you guys are the front line, where it takes us 10 to 15 minutes sometimes to get to these very rural. I mean, we're rural here, but I mean, you get farther out, it's even more rural. So on the way, we can do our 12 lead, we can get an IV started, we can draw blood. That way, when we come in, we can go straight into CT, already get their labs to lab, and get that those levels checked. And that's 10 to 15 minutes at least ahead of time there. Because usually it's an hour from like the time that you guys see them to the doctor sees them, that you get blood drawn.
It can be. Of course, we try to speed the process up. A lot of people say, well, stroke isn't as important as a heart attack. Well, it is, because the longer that they're having a stroke, the worse their deficits are. So the quicker, the better. And then EMS, when they come in by EMS, it's very helpful. But I mean, I don't really know an exact time, but it could take up to that.
Well, 15 minutes is 15 minutes at least, and that's another 20 minutes, or 10, let's just say 10 minutes. So 10 minutes to see and 10 minutes back, that's 20 minutes right there. So
is there any reason or situation where we would do a POV?
Sometimes, of course, if the patient requests it, don't you think?
That, or like it's nothing for both of our ambulances to be tied up. So you can look at it if you're on the west side of the county, and it's going to be a while before Baxter gets there. It may be quicker to get them there by POV. And again, with the east or even with the north, it can be the same way. So
we don't want to do that.
Huh?
The family member wants to do that.
Yeah, not near
Yeah.
Yeah.
Something that could be helpful though, if they do have to go private vehicle, if the EMS is all tied up, if they demand that they go private vehicle, if y'all could give us a phone call and kind of give us a heads up. I mean, I don't really know, are they allowed to do that with HIPAA and everything?
Yeah.
Give
Because
information.
they're part of the chain by that point in time, because there's information they have to have for their reports also. So
Okay.
Or get a helicopter.
Well, helicopter versus stroke center. So what she's explaining is that Fulton County actually is a stroke center. If you go anywhere here locally, they're going to put them on the telehealth, which is either going to be in Fayetteville or Little Rock.
It depends on where the neurologist is. Sometimes they're at their own house.
Okay.
But when we call, the initial call goes into UAMS at Little Rock, and then they get the neurologist that's on call, and that could be Fayetteville, Little Rock.
So they're going to receive the same treatment and the same medications that they would at a larger facility at White River, at Baxter, is what they're going to get at Fulton County. And I think that's a big misconception. Is like, well, Fulton County is not going to have what I need for this stroke, and they do. They do.
That's one of the things they worked real hard about, was get all these little rural hospitals on board with this program. so
Well,
that
I
he
was just
could
going
get
off from, if the ambulances are tied up,
Mhm.
what would be better? I was under the assumption that the air vac team has almost everything on their copter that they do in the emergency room.
Yeah.
But you still have to spend that time, flight time. So
So you're saying if no ambulances are available and you think you're having a stroke, you would recommend that they take them in their vehicle rather than get a helicopter?
I think every circumstance is gonna be different, you know, it depends where they're at. Are they here in town or if you're gonna have to go set up a landing zone? I mean, you're wasting all that time. So if it's quicker to go POV, definitely recommend that over waiting for a
And it's
helicopter.
not anything to call dispatch and say, what's the ETA of the bird? How long will it take them to live? Because they may be busy too, and you may get somebody out of West Plains, you may get somebody out of where's, what is the name of it? Yeah.
They're all 30 minutes. to-
And another
Yeah.
thing, James, is the helicopter, they don't have the capability to get that head CT to distinguish if it's a bleed or a clot. And so they don't have the medicine, but they wouldn't be able to administer the clot busting medicine, TPA or TNK. So that's kind of another thing because, you know, they're pushing because they want us to have that. What's the goal time now? Is it 45 minutes?
It's still 60 minutes, but they're
Okay.
shooting for 45.
So that would be the biggest thing as far as that goes.
Well, yeah, it saved my dad's life whenever he had a aneurysm.
Yeah.
He had a stroke.
Like, where we're at, Early Point, that takes us an hour to get down there,
Yeah.
even from our houses. And then you gotta wait on the ambulance and drive their truck to Salem. Or wait on a helicopter, and there's nowhere to land up.
You live all the way down to Blake at Curly Point,
We don't,
If we
but
get
we
called
go
out.
around that whole lot,
and it's rough down there.
but it's just, you can't.
I know all of y'all are kind of from different areas, different places, but another facility that has the same capability that we have is the ER at Cherokee Village. They have the telehealth. Oh, is Calico anymore?
Yeah.
I don't know if they're still a stroke ready facility or not, but if they are, you know, Calico would be another option. I'd need to look into that further probably, but so if you're close, if the patient's closer to Cherokee, getting them there, I mean, whichever facility they can get to the closest and the quickest is the best, so for sure. Does anybody have any questions about anything?
You said bleed and clots. Is that two different types of strokes?
Yes, so if they come in and they're having a bleed, we would, of course, we would still get on with a neurologist on call. They still give us direction. If the patient isn't able to get the clot busting medication, we still are able to consult with the neurologist there. Not really. It's going to determine the head CT is going to be the biggest factor. And that's one of the reasons when they come in by EMS, we take them directly back there because that's what we need to see that picture to be able to determine where our treatment plan is going to go. But if they are having a bleed, that is something that UAMS can help us get that patient transferred out at a quick time and get them the help they need. So one thing I didn't talk about was in order to receive the clot busting medication, their last on well time has to be within 4 hours. So that's another reason why we're, so fast and in a hurry. And I know y'all go to such rural areas and sometimes it takes an hour for the patient to get to us. So, that's an hour that we've got to factor off of our time. So we're just trying to do everything as fast as possible. Well, they wouldn't do that at an acute setting. They would do it maybe later on after, they've either received treatment or not, or if they've gone to another stroke facility. So.
And if they do need higher level of care once they're at Fulton County, they will either send them by helicopter, we will go
Yes.
to like Little Rock or like Cox or somewhere like that with them. So
We try to fly a lot of our strokes out, which I know y'all know this, sometimes if it's cloudy, they can't fly, but we try to get them out as quick as possible. And that's a lot of times flying. So.
any other questions? We'll talk a lot about stroke symptoms tonight, how to recognize. Again, like we said, last class, just because somebody was talked to on the phone and they seemed normal, but they didn't know about the arm drift. It's the time that they were actually seen normally functioning.
Yeah, because y'all do like a kind of a condensed version of our assessment, and that's way you can determine.
Yeah.
Whether they're having a stroke, and that would be good.
Yeah.
Good to know. Too.
Heat strokes categorized the same.
We just had this discussion the other night because I didn't honestly, I'm gonna tell on myself here. I didn't even think heat stroke was a real thing. And then I got to looking it up and doing some research on it, and it is. And but it's yes, I need to send, I'll send that to you tonight. But I found it.
Are you on?
No,
Okay.
no.
Okay.
But I found a really good article, and it talks about heat stroke versus heat exhaustion. But no, heat stroke is not, it's not the same thing. They might have like altered mental status and things like that with the heat stroke, but it wouldn't be treated the same in the emergency department. Yeah.
But it's like, you kind of lose your way of speech, you start passing out, you don't really know where you're at, what you're doing. You lose bodily functions, but it's not, it's dead, it's.
Takes years to get over it too.
I think there's a lot of people I talk to, of course, I work outside every day, and it's just, I can't take the heat.
Yeah, and that would be, where you would be talking with the family or the patient, trying to kind of determine the prior, what happened to before, oh, you were outside for 2 hours in 100-degree weather. Well, we might start going down that route. So kind of getting a better history. So. All righty, well, if no questions, get out of y'all's hair.
Okay. Well, thank you so much.
Thank you guys very much. You ever have any questions, feel free to contact us at the hospital. We're always available for questions. So.
And I'll post the number to the emergency room on the board, and
Yeah.
then that way you can call in if you do, if the incident arises where it's our ambulances are tied up, it's cloudy, there's a herd of pelicans running across the sky and they can't fly. That way you can call in and let them know what's going on.
I know the other day we had that scenario where they had a stroke.
Yeah.
Facing the Viola.
Yeah,
And the
Yeah.
ambulance did show up, but they went and did a flight.
yeah, yeah.
Even just letting dispatch know, because,
Yeah.
they're good about calling us too.
If there's no cell phone service, that's another big thing. 'Cause y'all go out.
That's a secure point, we have no cell phones, no scammers.
Yeah.
Dispatch, they can call us and give us a little bit of a heads up too, and they've done that in the past. So I know whenever y'all have not had service.
Yeah.
We don't have so it's really to have to monitor the EMS radio with you guys.
Yeah.
Y'all's inside or something.
Yeah.
So.
Yeah.
Yeah.
Yeah, y'all have radios too, at the ER, right?
Yeah, we do.
That's what I thought.
We can hear when 2101 gets dispatched out, but we can't hear unless we switch the radio, which we don't because then it'd get messed up and nobody'd know how to fix it. But if we could switch the radio, we would be able to hear 2102, but we don't until they switch over to whatever channel it is. Yeah. So. All righty. Thank you guys so much. We appreciate your time and we appreciate all that y'all do. Thank you, Tasia.
You're welcome. Thank you. Thank you. Okay, well, there's a. Oh, yeah.
Yeah. I got it. Don't want to get one second. You're good. You're good.
says I want to knock that over. All right, so who do we owe gifts to? Prizes. All right. Just as a refresher. Anybody new here tonight? So in case you don't know, I'm Tasia. I'm paramedic. You're you're married to Matt.
It's a new world for you every day.
So bathroom is over here if you need it. If you smoke, just please step outside away from the building to smoke out there. We have water and stuff out in the refrigerator if you need water. I think that's good. Yeah. All right. So I need to apologize. I've been working on trauma stuff for next class, and so I had something on the brain, had trauma on the brain. So when we did DCAT BTLS last class, I said aim as amputations, and it's actually abrasion. I went back. If you need a video, this is being recorded, so we can go back if you guys want to review this for whatever reason. And I was editing for to upload it to YouTube, and I noticed that I said amputations on that, so I'm sorry. You can take me out and beat me later. So what does D stand for? C. P.
Now, everybody put up notes.
B.
If you like me, you can't read them. So.
T. L. S. O. Oh, I got quiet. P. Q. Somebody's been reading. R. S. All right. A. Alert. If they're not alert, they're not alert to verbal. Good. Okay, any questions on that?
Only one I remember out of that didn't even belong in there. It's credits.
Yeah, I don't belong in there, does it? I'm gonna double check. Okay, so Foster for tonight. Go ahead and pass it around. Sam's already signed it.
I got one up there for the fire academy, so all I want to search fire wire, it needs to sign that as well.
I hope we all got it right last week. I don't know.
Brett has national standards through this national EMS standards, what we talked about with OPA versus NPA, pulse ox, that, et cetera, et cetera. I told you I'd print it off. Again, this is just National Registry stuff. This isn't Fire Academy. You should be covered under the Fire Academy protocol. In the event there's a lawsuit, just be aware you're assisting. whatever, yeah, yeah, yeah.
Arkansas Fire does not require, EMRs to be master record. So they don't have to take master records to the EMR, whatever it's called.
So on the fire academy, like, I'm on the fire department, but I'm the junior program, so I can sign that other too.
Yes, as I told you earlier, the fire academy has proved you're maybe a junior, but on the academy, you're not considered a junior, you're a full blown. So yeah, you gotta get all that work. I need, if you haven't, anybody has not, you go onto the website and get their job page for them to the website as well.
Is that the
No, that's before, it's not social security number, but that's plain social security number.
Okay.
You gotta go on the website, Arkansas Fire County website, and actually has an application for this class. You gotta make sure you get out to the fire academy. I'll bring it up, we have to break something, kind of show everybody where it's at, so you have to get that done.
The next thing Brett's handing out is the itinerary that I forgot to print off last week. Should have all 5 nights on it. There's 5 pages there for 5 nights. So that's just for y'all to have. We went over it last week. So is there anybody here that didn't get the cheat sheets last week? Did you not? Come on up here. Okay.
You don't have to. Yeah, so the fire academy, once you take the actual test, so they don't require you to be master record. Now you don't have to test, but I would strongly suggest it if you're going to write anymore. The volunteer will not be recorded. And that's pretty much showing that you know what you're doing, you've had training. You don't take a test, there's no proof you know what you're doing. That's kind of where I feel.
And then there's an instance where you don't want those stuff.
Yeah, it's somewhat rare, you don't want to be trained. Me, I don't run first fire calls on this, I'm actually called. I'll carry back my vehicle, I don't do anything. I'll right back here, I'm not working, I'll drive right to going, I won't stop. I don't want, you don't have to. Always, I'll stop first fire.
We will some. Yeah, that's more for us. We kind of went over it a little bit the first night, but just as an overview where you guys kind of understand, because that's another thing too, we were discussing earlier. I want you to be able to know what we're doing if we need somebody to pull up in the back of the truck. Because you'll hear us talk about, especially like with the helicopter, you know, GCS of 15 or 11, you know, when we said, you know, the highest is a 15 and a dead person gets 3, that's that Glasgow Calm scale. And we'll kind of go through it a little bit tonight, but you guys will mostly do the ASPU. That's what you'll do.
But that's not really covered with this. We get paid by, which most farm departments pay $10, $15 per call. That's the conversation. This main law will not cover it.
Okay.
Okay, so it says that if
We are.
say, you don't have the medical injury, slight injury, but you notice that awareness suspects of dementia, but it says in the book that we're not supposed to stop.
It's a good little conversation. You're getting like, so.
If they refuse treatment with dementia, so, suspected. Okay. So anytime that a patient says, no, don't touch me, we actually had this incident happen. We had, and I'm sure that you guys have heard the address go out. He's on 1920 D-Day Road. Yeah, and he's a little peepaw that lives in a garage. He's got a 1-room, I'd say, what is that, about 6 foot by 10 foot little room. And he's got it set up, he's got a little kitchenette, and he's got his bed. Home health comes in and sees him, and he's got some early onset dementia. The last time I was out there, I think he just had a really bad dream. He's like 90-something years old. He said that these people broke into his house and they poured acid on his hand and this, that, and the other. And Elite Home Health got upset with this because they wanted us to give him a shot and put him in the ambulance and rush him to the hospital. And the problem with that is that Glasgow coma scale, he was alert enough to tell me what day it was, the situation, and he did not want to go. So if I put him in my ambulance, that's battery. That's kidnapping. Yeah. And if I give him a shot and him not wanting it, that's assault. So it put them in a tight spot, and it puts us in a tight spot too. But if somebody just says, no, don't touch me, don't touch them.
I ran into an incident where I stopped at a motorcycle wreck, and the guy told me, said, I'm an off-duty EMT. He's sitting on his hip, rolled over on his elbow, and his head shaped. He's got a head whack. He's sitting there dripping blood. And he said, I'm an off-duty EMT with this service. My name is this. He said, I don't want you to touch my head because I don't know if I have a fracture. And I said, okay. And I grabbed, all I had with me was brawny paper towels. I grabbed a handful and I laid them next to him. And I said, I'll let you go for now, but if we don't get help here pretty quick, I'm gonna have to do something. He said, that's fine. I went to check on his girlfriend. So everybody gets there, we file him out and her, and so me and her was talking about it later. She's real good about decompressing me. And do you have any questions? Do you have any? And I said, yeah. I said, I really felt that I probably should have started working on him. And she said, well, if he told you no, then.
We're anesthesiologists, surgeons, emergency medicine physicians.
Sorry.
If we don't have a family there or know their medical history,
Right.
and they refuse treatment, so we don't treat them, and then later it comes out that they did have to be just, oh, we have fault.
Well, no, if
he
you
can
have
tell you
asked
the
him,
day.
who's the president of the United States? What's today's date? You know what today is? He's answered the questions that
What's
you
your
need to
name? How old
answer.
is he?
Right.
He can answer.
Yeah.
At that time,
What happens if you come up on a car accident and the person is absolutely refusing to leave the scene, but he has an obvious name? Or they have an obvious name?
Refusing to leave the
Yes,
scene?
he does not want to be treated, he does not want to be. You signed it.
Yeah. Well, I mean, we can't make anybody go with us, and we can talk to him like Sarah was talking about, trying to, let's talk to the ambulance service. I can't tell you how many patients that I've seen that, I've had a gentleman that broke his leg and he's like, I'm not gonna go to the hospital. Like, okay, just let you know. And if you ever sit on scene with me, you guys have seen the form, you've signed the form, and I have a list about, any other means by transport other than an ambulance. There's a liability there. And I make sure, and I usually run through it 90 miles an hour, but because a lot of times, these are regulars that we go out on. And so I don't have that memorized yet. I should have it memorized as much as what I say it, but that keeps us out of liability. And that may be something fire departments may need to look at, is maybe an AMA form, even for your lift assist. You get out there, you don't know why they're falling. They've got, they've got some weakness. We've just talked about stroke. It could be a mini stroke. And you call us out there. Of course, anytime you have any questions or you're concerned, you can call us out. We don't mind coming out. But if they're just adamant that, no, I don't want an ambulance out here, that may be a time to get a form signed saying, that we are released of any kind of liability from this situation. So, and always in that, what's that? Anytime that you get called out like that, always be sure to tell them, call us back if something changes, call 911 if you change your mind and you want to go back. and, and initiate the 911 system again. That's usually how I end my little spiel with them is, call us back. And when I write my report, I always say, patient was encouraged, patient and patient family was encouraged to call 911 again if there was any change in their condition or they changed their mind. So.
She knows he does it, but she does it about 5 times.
Who, me? Yeah.
So if they're getting in, okay, well, if you need us, just call us. Okay, okay. Well, if you just need us. Just
Yeah.
on the road.
Man, if we have time, she can text a regional report. And she's one of the most detailed reports. Her boss says that I can sit at home and read the report, know exactly what happened. On the call, what happened to the patient, how this happened to them.
That's great. If it's not
So-
documented, it wasn't done.
That's right.
Yeah.
Always protect you.
Yeah. Okay, so any other questions? Okay, so this little loud video that we got going here is kind of an overview, just a refresher of what we did last week. Some A&P of the respiratory system. Little short videos.
As we take a breath, air enters into the oropharynx and nasopharynx through the mouth and nose. Here, the air is warmed and moistened before it continues on down the larynx, which contains the vocal, down the trachea
Right here.
and into the left and right main stem bronchi. The area where the trachea splits is known as the carina, and you'll notice that the right main stem bronchi is wider and straighter than the left. When a small object or food inadvertently enters the airway, it's here in the right main stem bronchi where it will most likely become lodged. In the lungs, there are 3 lobes on the right: the upper, middle, and lower. On the left, there are 2 lobes, the upper and lower. The main stem bronchi then divide into smaller and smaller bronchi before becoming even narrower as they branch off into bronchioles. The bronchioles terminate into individual alveolar ducts, which contain alveoli, and it's here where gas exchange will occur. The alveolar ducts are connected to capillaries. Carbon dioxide diffuses from the deoxygenated blood into the air of the alveoli. And just the opposite, oxygen diffuses from the in the blood before it is ultimately pumped throughout the body. Most people have no clue that in 2023, the best way is not.
Okay. So, clear as mud? Okay, good deal. All right, so probably wondering why the CPR mannequins were out. As most of you know, more seasoned EMRs are familiar with BVMs, non-rebreathers, nasal cannulas. And one of the things that we will concentrate on in CPR class is some call it the EC, some call it the CE method. And it's basically how you put your hands onto the mask. The most important thing when you're using this back valve mask is the seal. So anything that you see up here, we have gotten adult sizes primarily because we use it more often. We're more familiar with kids, but all of this stuff also comes in pediatric sizes. So in the event that you just have an adult size and you need a smaller size, you can adjust. We had a child this last shift that unfortunately passed away, and there was, I think you guys just had an adult on scene, didn't you? And they adjusted it to where that they could do respirations, but you know, any respiration is better than no respiration, right? So you just got to make sure that you get it away from the eyes, because you can blow those eye sockets out if you get it too far up onto the face. So So we're gonna start out with the most simple. This is a nasal cannula. Choking with them right quick.
Trying to give you a scenario.
So our choking victim here, we have unclogged his airway, his O2 stat's good. So you guys can open the packages that are on your table if you would like. And as we're going through this, you kind of look at them and pass them down the line. I'm sorry. I just got 3. I know we got 4 tables. I thought we would be in the courthouse. I'm sorry. If you went to the courthouse and you didn't get the message that we're here, Quorum Court has their meeting tonight. So they've got the building tonight. So that's the reason why we're back here. So maybe next week we'll be over there. Yeah, I talked to James and he was like, well, we can't have the building. So I guess they took up the whole building. I'm not sure. So for whatever reason, we're here. Maybe so. Yeah, maybe. So the nasal cannula, there's 2 prongs. Typically, when you put a patient onto a nasal cannula, it's going to be between 2 liters per minute and 6 liters per minute. Please don't put a patient on 15 liters on one of these. I know you guys are all smart and very efficient. And if you do this, what we talked about liability, you said I put them on 15 liters. I'm going to hold you accountable. And I'm not going to cover that. And I'll probably talk to the chief about that too. So there's 2 different ways. There's a curve. You want to make sure that curve is toward what's called the septum that goes up into the nose. There's a couple of ways that you can attach this to the head. Once you get it into the nose, I would put it in first before I attach it to the oxygen. That way you're not fighting it. They're tickling and they're moving. It's tickling them and they're moving. So this is the general way. Put it around the ears. There's a little slip knot here and you just pull it up. That keeps it in place. And of course, we've got the O2 end here. The second way to do it. Yes. Yeah.
So do you like to turn the oxygen on first before you put it in their nose? Or do you like to put it in their nose and maybe accidentally go the wrong way with the dial and hit 15?
Again, I'm gonna let you deal with that. Uh-huh.
We're gonna stick to the department protocols for that.
So what I've actually did here is I put the nasal cannula up the nares, and then I have went behind the head. And I just pull my prong up that way. That's also sufficient. This could be, you know, your little meemaws or peepaws that are on constant O2. You're switching them over to yours because you know we're gonna have to get them outside the house. So you're already getting that started. It may just be that their ears are raw. So that's just a way that it can be just a little bit more comfortable for them. So Brett was kind enough to bring in a oxygen bottle here. I'm actually pretty excited about this. Is when I teach these tools, I usually don't have an O2 bottle full of O2. So
Does everybody here know, this is not your normal bottle. This is one to carry on the ambulance. Your normal bottle doesn't have a regulator on it. Does everybody know how to put your regulator on? Make sure you load the yellow things in there to seal up.
I think everybody in this county pretty much uses these, right?
Oh, do they?
Well,
Yeah.
No, we
You don't? Okay.
Well, if you have to put a regulator on, there is a little yellow that goes in there. If you don't, it will sit there and blow out. So, yeah, it's an O-ring, it's just plastic O-ring. And keeping up with your little wrench is next to impossible.
So on our bottles, when you have a fresh bottle, it's going to have this black piece on the end of it. Pull that off before you try to apply the oxygen. And I know that you guys are like, that's really dumb. Like, why are you telling us that? When things are hectic and somebody's like, why are you not doing something? You forget these small baby steps. So if we don't cover it in class, it may be we make a mistake. Well, she didn't teach me that. I want to make sure that I give you as much information as what I can. So you have your regulator up here at the top, your little gauge. 2,000 pounds is full. Typically between 600 and 800 is when we change out these bottles and also our main O2 bottles or big bottles in the truck. I think this will last probably on 6 liters for about 30 minutes. When you go down to 2, 4, it'll last, of course, last longer than that. So what you want to do, this is a non-rebreather. The reason why it's called a non-rebreather is because it's got a little tabby here on the side and it doesn't have it on this side. If it had the tabby on this side, it would be a full rebreather. But I've never seen one of those in 20 years. The science behind this, I really don't know. Y'all might not be interested in the science in it, just want to know how to work it. So if anybody's interested in that, I'll research it for you and present it. I don't mind to. But what you do, the elastic, of course, goes around the head. You can adjust it, make sure that the mask, it doesn't have to have a tight seal, but it needs to be able to sit itself upright on the patient. Once you get these on too, if you have any questions for the patient, make sure to ask them before you put it on, because between the oxygen and them, you know, their voice being muffled by the mask, it's hard to talk to them. You can bring it out like Kristen. Yeah. 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 So up here, around here, it's not going to be sufficient. If they can't keep it in place, just say, hey, can we take that off and maybe keep it in front of them? Because again, some oxygen is better than no oxygen, right? Some is better than none. So I'm going to attach back here my tubing. Up here at the top is how many liters per minute. So when I turn that bottle on, I'm going to turn it up to 15 liters. As you see, it's going to fill up. If you put your fingers over the top of it, it's going to fill up more, or it's going to fill up quicker. So this is when you're going to place it on the patient's face. So basically what's that's going to do, we talked about last week how it's actually your CO2 drive that assists or makes you breathe. It tells you when to take a breath, which is the reason why you yawn. Because if you're sitting there and you're sedimentary and you're breathing 10 to 12 a minute, your brain's not getting sufficient oxygen, so you're getting a yawn to take in that big deep breath. So a lot of times in the middle of the night, you see your husband, your significant other, your wife, or your kids sigh. That's the reason, is their CO2 is built up and their little bodies, their big bodies, are needing some more oxygen. So
All right,
She
we're
looked at
quit
you.
snoring.
So any questions on that?
Now,
We don't have a little white spray on the side on this side. Is it different type?
Is it not on the other side? No? Oh,
does it have the two?
oh, okay. Well, I
So
don't know.
now, from now on, anytime you watch any kind of medical show, watch and see if they inflate the bag. Because we watched 11 seasons of ER, and not one time did they ever inflate that bag. You piss her off so bad.
So what was your question? No? Okay. So up to how many liters with this? 6. How many liters with this? 15. Good. Okay. So Mima that's on Homo 2. She has 968 feet of cord where she can run around her house and do cartwheels out in the yard, go to the mailbox, or whatever she does on that. She said, I'm just short of breath. It's because she's on 968 feet of cable. So bring her down, even if she says, well, I've got a concentrator. If you shorten that length and put her at least on her concentrator, her O2 stat's going to go up. So what's our normal O2 stat? Did we talk about that last week? What is it? 95? Huh?
As an experienced
Fire Academy. Fire Academy, you can. So, 94 to 100. Yeah. Yeah. And your COPDers will be different.
COPD will be on 15 liters of oxygen, so
Yeah. Yeah. Okay, so this is your back valve mask. This is the reason why we have the mannequins, because I know not everybody's gonna go through the CPR course, and it's just a good refresher to be able to get that EC method, CE method. You think, well, I can do that. We still have to practice intubation when we put the tube down the throat. If you get out of practice and you don't use it for a while, it's just like anything else, you know. If you look at telephone numbers, you know, we probably remember our telephone numbers when we had landlines, but now that we try to call somebody, we don't know the number because we don't use it anymore, right? We just see their name and hit it and just go on. So this is something that is important, but you want to make sure that you get a good seal on. Again, it's the same 15 liters. I hook it up. This has also got a reservoir. This is the reservoir bag. It is also 15 liters. If you do anything less than 15 liters, you're going to suffocate that patient, because with the cannula, I mean, you've got two little prongs, but they've got natural air around them, right? So they're able to take in more oxygen. But when you get this seal around their face, that little 6 liters, that little 2 liters that you're doing on this bag is all they got. So you want to make sure that you get that at 15. So old standards used to be, you take this bag and you just push just as much oxygen as what you can in there. We don't do that anymore. Science has shown, statistics have shown that when you do that, you make them throw up and you'll blow a lung that way. So you want to make sure that you're getting adequate chest rise. That is key term. The key term is adequate chest rise. My hand size and Brett's hand size and Bernard's hand size are all different sizes. So if I say, well, just give them a handful of oxygen, well, that's going to be different for each one, right? And, you know, Nanny is not going to need as much as Bubba's going to need. Yeah. So, again, adequate chest rise.
Right out her nose, you start having nose bleed. Had to take it off. Our nurse is freaked out. I mean, just the nurse is freaked out. They didn't know what to do. But what do you do?
Did they have a nose bleed because of the dry air or?
Too much air. She was on 12 liters of oxygen.
And so the video you seen, it said when it enters, that's to warm that, that's what it's doing. Dehydrated.
Also, you said look for chest rise, but we also look for abdominal bulging.
Yeah, that goes along with your EC method. We'll talk about next week, especially about the head tilt, chin lift, and the jaw thrust. So if you're having abdominal increase, if you adjust that head and adjust that airway, you can use an OPA. We talked about the oropharyngeal airways. If you use an OPA on them, it will bring that tongue down where you can get that air tube more, because the esophagus sits behind the trachea. Trachea is the air tube, esophagus is the food tube. So if you're crunched up, the first thing that's going to crunch up is the trachea, right? So the esophagus is the one that's going to be open. So if you position that head up, it's going to open that trachea, and you're still going to get a little bit of oxygen, a little bit of air into the belly, but not near as much. So the EC method, if you can see, head tilt, chin lift is just lifting up into the sniffing position. The nose is going to be up to the ceiling. I'm going to put the mask over the top of the nose. Your pointed part goes over the nose. This part, the round part, goes to the chin. You want to keep them in that sniffing position. See, it's hard for me.
You got pretty straight chin.
Yeah, you did. There we go. See that? So if you can't get it one way, if you're on this side, I'm left-handed, so I have to do a little bit different. You can rotate around. If it's a lot of work for you, make it as less work as possible. Don't make anything harder on you than what it needs to be. Okay. So if it's on this side and Meemaw's not up against the wall, Even if she is against the wall, if you have to do an emergent move and pull her out for whatever reason, do that first. Get her out into the living room, get her out to the front porch. Front porch would be great. But it's way more than likely can get her cot closer to her than what we can if she's in the hallway or in the bathroom. So, any questions? How many liters? 15, good.
So.
Okay, all right, so it is 4 till. We'll go ahead. We'll come back at 7:11. Or 7:06. I'm sorry, 7:06. If you have 2-person and you have the equipment, do compressions and respirations. If it's just you and you don't have your equipment, do the 100. Yeah, with no respirations.
That's for me to the back end, make sure that's all right.
Is that too loud? Is it okay for everybody? A lot of it will, yeah. Again, I'm probably giving you too much information and probably information that you won't ever use again. But for testing purposes, I want to make sure that you guys are equipped, okay?
So the exam, is it gonna be just questions that us as EMRs are gonna be allowed to do? Or is it gonna also be things on there we're not allowed to do?
It's gonna be Fire Academy standards. Yeah, what Matt is saying, where y'all can do the pulse oxes, talking about the spine boards and stuff. I'm the EMS side. So if you are nationally registered as an EMS first responder instead of a Fire Academy first responder, then you'll have to follow the national protocol that I passed out. But the Fire Academy side, they're still teaching all of this.
And so that's the test we're gonna be taking.
It's Fire Academy. Yes. Yes. No. No. I know I've got you nervous about it.
Yeah. So this Matt's gonna be teaching us some stuff.
Yeah. 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 Okay, so we're gonna watch a few more videos. Okay, so I will Fulton County's got a Facebook page, yes.
You print out like a sheet with you to the name of the video.
I tell you what, we've got this big screen. I'll go to it here in just a little bit. Will that work? Yeah. Yep. Will that work? Okay.
This is Rachel.
That would be a Matt question. Yeah. Yeah.
Rachel was a science teacher and she is.
Well, Rachel, I don't care about Rachel.
I think the principal now is good. I don't know why it caught my attention. I look over there.
Are they wearing tights?
Yeah. You gotta look apart. Yeah, but that's where our turn.
What is the mechanism that allows breathing, and is it an active or passive? First, we have to understand pressure. Outside the body, the air is 760 millimeters of mercury. At rest, the intrapulmonary pressure is also 760 millimeters of mercury. An important concept to remember when we talk about breathing is how gases always want at least resistance, moving from areas of high pressure into areas of low pressure. Breathing consists of two distinct phases: inspiration, inhalation, and expiration. During inspiration, the intercostal muscles will contract and move outward. The diaphragm will contract and move downward. Notice how this increases the volume in the thoracic cavity and subsequently lowers the pressure inside. As a result of the larger volume, the intrapulmonary pressure has dropped within the lungs to 759 millimeters of mercury, causing air to be drawn in from the outside. Due to the contraction of the muscles, we call inspiration an active process. During expiration, the intercostal muscles and the diaphragm relax, causing a decrease in intrapulmonary volume. As the volume decreases, there's an increase in intrapulmonary pressure to 761 millimeters of mercury. We understand that air moves from a higher pressure to a lower pressure, and as a result, air is moved from the lungs out to the atmosphere. Due to the elastic recoil of the muscles relaxing, expiration is considered a passive process.
All right, so if breathing is not adequate or stopped, carbon dioxide accumulates in the body cells and becomes a deadly poison. A patient who is not breathing adequately is said to be experiencing respiratory compromise. Cells begin to starve for oxygen, which is also called hypoxia. So when you use your pulse ox, oxygen, right? High, Hy. Hypoxia would be high, and in that case, it would be high carbon dioxide. If adequate breathing is not restored quickly, the patient goes into respiratory arrest or stops breathing. Causes of respiratory compromise could be asthma, bronchitis, heart attack, severe allergic reactions, as well as exposure to toxic substances, inhalation of superheated air. The absence of breathing is called apnea, A-P-E-N-A. You probably see that a lot. Apneic, patient is apneic, stop breathing. At the moment, both the heartbeat and respirations stop, clinical death occurs. So I made all these notes for Brett because I didn't think I was going to be here. All right, so if the patient's cells do not receive oxygen within 10 minutes, irreversible death may occur. This first occurs to brain death. What we were talking about with stroke, Sarah said time is brain. After 10 minutes, you start getting those signs and those symptoms that they're not getting adequate oxygen. So you guys being on scene, you're the front line. You know these patients, you get to them in 2 or 3 minutes. It's going to take us 10 minutes. You guys are it. You guys are the star players. Breathing is an involuntary automatic function. To inhale, the chest cavity increases and the pressure inside decreases. To exhale, the diaphragm muscles and the muscles in between the ribs relax, reducing the volume, and air flows from high pressure to low pressure. When an airway is open and clear, it is said to be patent. When a patient is in respiratory distress, the most obvious sign is an increase in the work of breathing. Look for adequate tidal volume. Your tidal volume is what we were talking about with the Ambu bags. This is going to be a bigger tidal volume than what this is. So What we were talking about, Bubba is gonna need more tidal volume than what Meemaw is gonna need. Listen for air entering and leaving the nose and mouth. It should be quiet like a soft breeze. If a patient is unresponsive, feel for air movement into the mouth and the nose. Observe the skin color. The skin should not be pale or cyanotic. And observe the patient's level of consciousness. Normal breathing cannot be assumed in patients who are conscious and talking. And again, this says consider your time factors. What would they handle in a situation involving, or what would you do in a situation involving multiple patients? What would you do? Huh? Worst one first. Good. Yeah. Yeah. Signs and symptoms: increased work of breathing, absent or shallow rise to the chest, little to no air heard or felt in the nose or mouth, noisy breathing or gasping sounds. Breathing is irregular, too rapid or too slow. Breathing is too deep or labored. Use of accessory muscles in the chest, abdomen, or around the neck. Nostrils flare when breathing, especially in children. Skin that is pale or cyanotic, sitting or leaning forward in the tripod position, making breathing easier. And abdominal respirations, which are slow, sporadic gasps of air from the unresponsive patient. So what can altered mental status tell us about breathing? Good. So rescue breathing or positive pressure ventilation is when a patient is unable to breathe in without adequate rate and volume to sustain life. So you may have a patient that's got a respiratory rate of 6 or 10, or they may have a respiratory rate of 20, 22, and they're still not breathing normally. They're not breathing sufficient enough to keep all of the organs working. So you may have to assist them with a BVM. Just make sure that when you're assisting them with the VVM or BVM, that you are putting air in when they're inhaling, and then let go of the bag when they exhale. Don't fight them for it, because try to use, again, make it easier on you, make it easier on the patient. Try to get them with what cycle they have left to get the air on the intake. Okay.
So it'd be better to use that than put the nasal thing
If it's inadequate, yeah. If you get the feeling that they're circling the drain and they're fixing to go unconscious and they will tolerate the BVM, yeah, you can use it. We use it some in the ambulance. Then we have the CPAP too that we use. Yes.
So what if you go POV and you don't have those? What else do you need for that?
Keep them calm. Keep them. Basically, you're there. If you check their pulse ox and it's low, you give us a heads up. We will bring that in. Usually, I'm the world's worst. People make fun of me because I literally bring a trunk to work, and it's got everything in it, anything that I could need in it. It's got all my bedding in it. I've got 2 or 3, my wagon, my little red wagon that goes with me everywhere. I've got 2 or 3 sets of clothes in it. I do not like to be unprepared. So on the back of my cot, you can see the same thing. I've got, we've got a nasal cannula that what we call capno, which actually measures the carbon dioxide level. We can do that on our monitor. So I've got that. I've got a regular nasal cannula. I've got the non-rebreather, the Ambu. I've got a mega mover. We usually grab the blood sugar glucometer if we need it.
Right now we got a nasal, nebulizer, non-breather, pulse ox, a peds and adult, blood pressure, BVM. I got a blanket, a sheet, and a regular.
And I get some medics that get in there, which is totally fine, because when you're on that ambulance for that day or for that 48 hours, that's your truck. You can set up the way you want to, and they'll pull that out. I don't want, because sometimes we're gonna push that little tray in, get around corners and stuff, and that's a lot to take off. But when you need it, it's there. So, yes.
So if they pass out, you just start CPR at that point.
Yeah. Which actually, this actually brings up a good point. So if you don't have that, there are several things, and this may be something to talk to your fire chiefs about. If you go to any kind of event and like survival flight or airback is there, sometimes they have these. They have these what are called pocket masks. They're the older style. It's the same thing as what the Ambu bag is, except it doesn't have the bag. This one's the old one. Yep, it's this way. So this is the filter. So you screw that on, you're gonna breathe through here. You're gonna get your CE method. It's got an O2 if you've got supplemental O2. But a lot of people keep these. I have actually a different style that I keep on my key rings. And I picked it up when we worked at Children's Home. Airback was at a event for the kids and they had these little pocket masks and it just stays on my keychain. Do you? So it's just a little pocket, little plastic piece comes out. It's got a little filter on it. So I can give respiration when if they pass out and they're not breathing, you want to make sure that you check their pulse. And if their pulse is not adequately functioning, then you start CPR.
So they got a good pulse at the moment.
Right. You can assist with respirations with either one of these. If it's somebody that you're comfortable with, that, you know, it's not crackhead Lucy that works in the corner.
Does Tommy need to put on lipstick?
So those are a couple things to invest in. Like I said, talk to your fire chief if that's something that you think would be beneficial, just to keep in your personal vehicle if you don't have your EMR bag with you. I think we've got stuff in Brett's truck. We've got stuff in my car. I keep this on my key ring. We're usually not very far off from any kind of equipment.
Most of the time, to tell you the truth, it's outdated hospital stuff.
Yeah.
When we put on that class out here, everything we used was outdated. Now, a bag of saline is a bag of saline. If it's out of date, I didn't care after I've had the flu 3 days. Hit me with it.
Amazon has a lot of it too.
Amazon has a
Yeah.
lot of it. Most times, if it ain't drug related, if it goes out of date, the hospital's throwing it a bucket. And so classes like this, it's used to help with education. Yeah, it's good for education. So.
Also too, if you have somebody and they're borderline, you're like, well, you're breathing okay right now. You're not breathing real good, but I don't want to waste my equipment in case I have another call. We'll replace what you use off of our ambulance. Just say, hey, I need an ace cannula, I need a BVM. Even if you need to come and meet somebody at the hospital, you know where our quarters are at, or I hope you do. We are over by the clinic, the Northeast Arkansas Clinic, Renee Crowell. There's a little house there now. It's got a little table and chair sitting up front. So that's our quarters. So just come knock on the door. Or if it's Monday through Friday, 8 to 4, our director should be there. You can ask, talk to him if he can get you some supplies to replace. So yeah. Yeah, not 2 a.m. Yeah, not 2 a.m. I will give it to you. Okay, so we talked about the head tilt chin lift, which is the sniffing position. You just push that forehead back and it pushes the chin and the nose up. There's also the jaw thrust. That is if there's a spinal injury suspected. So grandma fell out of bed, that's iffy. If she's complaining of neck pain, you probably want to do the jaw thrust. And grandma fell off the bed and she didn't hit her head and she's just complaining of arm pain because she cut herself. Probably do the jaw thrust at that point in time if she passes out on you. So the jaw thrust, basically what it is I'm in this position and I'm just pushing up on the jaw. So I'm not actually pushing up on the forehead, pushing that spine back. So it's just up here in the front. See the difference? That way.
So would that work with somebody that has dentures too?
Take dentures out.
Yeah, they take dentures out.
Yeah.
it's still kind of-
Yeah. Huh?
The book said it's about an exaggerated.
Yeah, you're gonna pull,
Get it to the core.
yeah, you're pulling that jaw out and up, basically is what you're doing. Instead of manipulating the spine, you're trying to restrict that as much as possible. And if you've got them in a seat collar too, the seat collar is gonna put them in that straight inline position anyway. And you can kind of get up in there and do that jaw thrust also. If you get a patient and you say, well, that's a trauma patient and I've got the seat collar on and I'm not sure I can do the jaw thrust. Think about what's going to kill him first. Is the spinal injury going to kill him first, or is not breathing going to kill him first? Not breathing. So what are you going to do first? Not, you're going to do respiratory, right? Okay. All right, an unresponsive patient, the muscles begin to relax and the tongue can drop to the back of the throat and obstruct the airway. We talked about that. Tilting the head and lifting the chin can relieve it from its problem. It is impossible to swallow your tongue. I know we've got a lady that's older that works for dispatch. I was in Mammoth one time and she dispatched us to a call and she paged us out in the middle of the call to tell us to hurry up if the patient was swallowing his tongue. You cannot swallow your tongue. Your tongue can roll back on that trachea like we talked about, but an OPA will fix that, right? It'll bring that tongue up. You can't swallow your tongue. So, I think that goes back to the old school
That
heat
is,
stroke.
because the time you talk about that seizure, they thought they all.
Yeah.
They would have to put
I mean,
something in
unless
the
you
mouth
just bite
to
your
bite
tongue
down
off.
on.
Yeah. Yeah.
Tourniquet on the tongue would be.
If the patient is lying down with his head on several pillows or up against an object where the head is flexed forward, tilt the head back slightly by removing a pillow or repositioning the patient so that his head is not flexed forward. You may place one flat pillow underneath the patient's shoulders to maintain the airway. Why would you put it underneath the shoulders? There you go. Good job. If you don't have a pillow, you can do a towel. A lot of times when we are intubating, we will actually pull the patient all the way down where their head is cocked back on that cot. It's kind of hanging off where we can get our scope in there and we have a direct line into the airway. So again, just trying to make it easier on trying to facilitate helping the patient, making it easier on ourselves. All right, so
So what is ClickUp? ClickUp is an all-in-one productivity software where you can manage everything and anything related. Okay, guys, now we're going to talk about hyperventilation, proper ventilation of the patient. Think of the last time you went on a cardiac arrest or RSI, and after the patient's intubated or when you're bag valve masking them, you're doing it way too fast. So this is what this looks like. Look how that lung just keeps inflating.
Well,
and that's not good.
Yeah, there we go.
Yeah.
Okay, guys, now we're going to talk about hyperventilation, proper ventilation of the patient. Think of the last time you went on a cardiac arrest or RSI, and after the patient's intubated or when you're bag valve masking them, you're doing it way too fast. So this is what this looks like. Look how that lung just keeps inflating. And that's not good. That increases interthoracic pressure, decreases preload, decreases stroke volume. And it's really bad for the restricted lung patients because they don't have time to exhale and they have all that air trapping. So what I want you guys to think about next time is just doing it once every 6 seconds with one hand, hold it like a football, just using those fingers, just like that, just enough to watch your chest rise.
Can I it's kind of just shows you what's actually going on inside of the body. We're the world's worst. I will just let you know when we're on stage and we're talking and we're not keeping up with the 6 seconds, and we'll get excited thinking about different things, thinking about what needs to be done next, trying to pay attention to what others are doing around us. A medic that works with us, he says how he calms himself, what he says to himself to make sure that it's every 6 seconds is he'll inflate, and then he'll say, boy, do I feel stupid. And then he'll inflate again. And it's kind of, if you take the airway position whenever you're working on a patient, your job's pretty easy. You're just sitting there bagging. So you kind of feel like you're not fulfilling your role, but your role is very, very important at that point in time. There's nothing really else to do in that situation. So another thing you can do if you don't want to call yourself stupid is Mississippi. Mississippi.
Okay, we don't spell.
Another thing, you can misspell it,
This is always in 6 seconds.
Another thing is when you're doing the whole 2-minute suppression and switching, it's hard to go from that 100 beats a minute to once every 6 seconds.
Yeah.
Once they're to jump back into 100 beats a minute. It really, and I know this because I don't know how fast I was bagging that guy before I finally realized, whoa, dude, you got to slow down. Because she relieved me and went to do compressions, and I went to bagging. And so, you know, you're still in your head going, staying alive, staying alive. It's really, it's especially, and this is my first time doing CPR. No! You know, so when you're doing that flip back and forth.
But you did that internally. You didn't do it externally, right?
It's really, you know, no matter what's going on, this is my job. My job is once every 6 seconds to squeeze this back. This guy depends on me to squeeze this bag once every 6 seconds. Despite what's going on. If she needs your attention, she'll go pop you on the back of the head and say, hey, listen to me. No, she won't. But it's really difficult when you're waiting on an ambulance and you're doing the whole 2-minute flip deal to stay in your time that you're supposed to be keeping up with.
And when you're switching, just go. And then the drill cuts yourself down.
Yeah. Yeah.
You gotta remember to breathe, take your place.
Yeah. Yeah. Any questions so far? Okay. I actually, that pediatric patient we had this week, and I actually had to tell myself to breathe more than what I would on an adult patient. So that was a little bit new for me. All right, OPA. OPA versus NPA or Fire Academy. Are they doing NPA? It's in the book. I do know that.
It's in the book.
Okay.
But
Uh-huh. For national. No.
This test, you need to know how to use it.
Yeah.
Okay.
Or what's the test wise, don't worry about what National Respiratory says. Go by that hood.
Yeah. Yeah.
Is there anything we could study about this book?
Could you give us here the chapters?
Yeah.
Not really.
Learn them.
Yeah.
I actually try to get that for test.
Can y'all make us?
You're trying to get the test?
I'm trying to, but
Don't look
I can't technically give you the test because I'm instructor. I'm trying to work my sources to actually get a copy of the test. Trying to get.
How many questions?
Can you get us?
But the way that they do it is I'll have like 10,000 questions in a, oh, no, this sugar line, push a button, and generate 3 questions out of 10,000 questions. So it could be anything. It could be all airway stuff. It could-
85% definitions.
Yeah. Yeah, it could be all trauma, the whole contact could be all trauma, it could be medical, it could be this, it could be stuff that you never thought about anything about.
It's instead of like turbidity test, once they find the weakness, they'll keep on that.
Nah,
It's
so
hands.
It's a, yeah, so no, if you take any fire academy class, it's basically same way. Is they go in, generate people quick test. So proctor come in, they'll give you all a test, give you an answer sheet, you fill it out, and then send it back to fire academy. So it ain't like EMT or a paramedic is if you start getting good at one section, they'll add more questions or, you good enough, go on, or if you start stuck in one section, or.
Oh, really? That's the moment you went.
Yeah, you don't know.
There's a good quiz behind after every chapter.
Yeah.
Yeah.
Those end of the chapter quizzes will generally be most of your tests.
Okay. Is there any practice? on
You already doing them?
Well,
I'm not sure I'd love to miss.
Yeah,
Why
that's
we've been going.
that's what I would do. Anytime state wise, I would do those end of chapter quizzes.
Is there any online?
Yeah, I don't know how much out there.
I'm not sure I'd love to miss.
Probably, yeah.
I don't
I
have
can
any.
teach any class.
Well, I figured somebody out there has got
Yeah.
I can tell you.
outdated tests.
So your OPA, your NPA, and your pulmonary, how am I gonna remember that? So we went over midterm, right? So oral is what? Mouth. Pharyngeal is the pharynx, right? Airway is airway. Nasal. Nose. So O, mouth, in, nose. Okay?
Until you do it.
I'm actually going down in a couple weeks to fire camp. Get credit to fire camp. But yeah, I can see. Here's me.
When selecting an oropharyngeal airway, measure from the corner of the patient's mouth to the angle of the jaw. As you can see, this one's too big. This one's just right.
Yeah, you can use an OPA. Yeah.
To 6th grades. And the answer is.
So, as you heard, they went from the mouth, right? Down to here. So it's gonna be the same thing with the nasal. You're gonna measure from the nose down. Okay? So the OPA,
I don't have any of those in my bag. I don't have any of those in my bag.
we have some. You wanna go find them?
I will get them if you'll.
Yeah.
For me, it's easier to see if I
Yeah.
see.
So they come all the way from infant size to bubble size. And they're color coded, yeah. So if you're ever on scene with a pediatric, you'll see us. We've got this little PD bag and we roll it out. It's got different colors. And we've got a tape called Brazil tape that we will roll out and we'll measure that pediatric patient, how tall they are, and that tape will tell us how many milligrams or kilograms they are. And tell us like our drug dosages, like when we intubate, what kind of tube we need to place into them, what medications that we need to give and what we give it for. So it's just like with the adult patients, you know, weight is key. If I want to give you morphine, I want to make sure that I give you enough morphine to be able to not take your pain away, but to kind of forget about the pain for a little while. So it'd be nice if they could have something like that for adult patients, but they don't. Okay, so these are lung sounds. These are kind of fun.
I'll let y'all pass these around. If y'all don't care, just gonna take about a
gag reflex? Unconscious person doesn't have a gag reflex?
That is a good question. The unconscious person can also have a gag reflex. So it depends on how relaxed that airway is. If they do not tolerate it, if they begin to gag, go ahead and take it out. If they do, if they start to throw up, roll them over. If you have portable suction, suction them out. Try to get as much vomit out of that airway as possible, because you're looking at what's called aspiration. If a patient aspirates, that vomit goes down into the lungs and that sets them up for infection. So if you don't have anything, again, what's going to kill them first? Not breathing or infection. So just do what you can. So when you're auscultating is just a big fancy word up to for listening. If you've got your stethoscope and you're listening to your breath sounds, this is what you should hear.
Bronchial breath sounds are considered normal when heard over the large airways. A good place to auscultate these sounds is over the second and third intercostal space of
I don't know why it's acting. Here it goes.
the anterior chest near the manubrium. Over 20.
Put it where?
On your own chest.
Mhm. So wheezing, we hear wheezing a lot when you walk into a room, patients wheezing. That of course is, you know, a significant sign that they're not breathing adequately, right?
Wheezing can be auscultated on inspiration or expiration. It's indicative of a narrowed airway, either in the upper or lower portion.
Yeah, there it goes.
Specific conditions that can cause wheezing include asthma, COPD, lung cancer, or CHF. Pleural rub is the name given for pleuritic lung sound.
Hush. Okay, expiratory wheezes. So you can have patients that have wheezing going in. They're not able to get in. Their bronchioles are really tight. So they're having a hard time getting air in. You can also have a patient that has expiratory wheezing, which is they can't get enough oxygen out. So a lot of times you'll see pursed lips, you'll see the accessory muscles, they're using everything they can to push all of that air out. So you may get a wheezing coming out too. You can try, yeah, that's a good idea. If they can, I tell them when I give them a breathing treatment into the ambulance, and this I'm glad you mentioned that, because if they have like an inhaler or they have a home nebulizer treatment that they do 2 or 3 times a day, you can help them, assist them with that. So what you want to do is tell them to push as much oxygen as they can out and empty the lungs out, make those lungs squeeze, and then have them inhale with that medication on their face or in their pipe or whatever it is, their inhaler, and get as much air as in the lungs as possible. Let them hold it, ask them to hold it for about 6 seconds, 15 seconds, if they can do it, and then have them push everything out. And let them do that as much as possible, and it will cause them to cough. It's getting that mucus and it's breaking that stuff up in their airway. A lot of times we'll get a patient on a nebulizer and they're Well, that's not doing them much good, is it? So if you can get them to exercise all of those muscles that have been relaxed or they've been stagnant, because they're probably sleeping in their recliner, they're not going to bed and laying flat. They're not getting up, and they may be getting to the refrigerator, and they may be in that recliner full time. They may have a urinal or something set beside them, or having, a brief on using the restroom while they're in their chair. So they're not mobile at all. So the more that they can exercise that respiratory system, the bigger the pressure that we talked about with the pressure, with the inhalation and the exhalation, that capacity will increase. And I bet some of y'all are looking at me like, oh, that's a lot.
Well, my question was, they can breathe, they can have high pulse ox, normal pulse ox, but yet have a hard time getting air in.
Yes. So that's what we talked about last class, about how the CO2 level will mimic the pulse ox, especially like patients where there's a leak. Is it carbon dioxide leak? Monoxide. Yeah, carbon monoxide leak. You'll get them on, they'll have that cherry red skin color, and they'll read 100% on your pulse ox while their deoxide level is increased. And again, that's something that we can check on our ambulance, and that our standard of care has actually changed. Anybody that's got an increased work of breathing, for whatever reason, we actually check their carbon dioxide levels with that.
It doesn't tell you what it's for. You put that on their finger.
Yeah.
You're assuming that's O2, but it could be dioxide, could be monoxide. Just giving you a number, you're going, oh, it's 88, 90%, they're good.
I have a hard time breathing.
And one of our deals at Horseshoe is a lot of times it's being with
In
them.
this video, we're gonna
But if we can put them on O2, that if you just think you just gave them the miracle drug. It's, oh, okay, and it don't matter if their legs been cut off. If you put them on O2, they'll feel better.
Yeah. And if you've got a patient too that's just anxious and their O2 is okay and they're breathing all right, they may be just breathing, their tachypnic, tachy is high, right? Put a nasal cannula on them anyway. You don't have to turn it on. Yeah, just knowing that you're doing something will help that. And if they say, well, I can't feel it, well, you can turn it on then. But we have those too. I've heard some stories. I've never done it, knock on wood. Well, that they'll put the stickers on their head, like if they've got a combative patient, they'll put one of the electrodes on their head saying, if you act goofy, you're gonna get shocked. So, and sometimes like our drug seekers will take like a saline flush, we'll push it, they'll think that it's medication and it's not really, so you get that. Yeah, just thinking that you did something. So yeah, if you ever hear nosoline, a normal saline, nosoline is the pretend drug.
Of course, they're gonna call you back tomorrow night for another shot.
Yeah. Yep. Okay, so this is the expiratory wheezing we were talking about.
review the expiratory wheezing lung sound. Typically, expiratory wheezing indicates some form of COPD, asthma, allergic reactions, anaphylaxis, some form of a respiratory disease that is anywhere from mild to severe. You're going to hear wheezing when you exhale and even when you inhale, depending on the person's condition. But typically speaking, if it's on both exhalation and inhalation, you have a more severe breathing problem that you're dealing with. Expiratory wheezing alone, in and of itself, can often indicate just a mild airway problem and something that's usually either self-resolves or prescribed medications.
Almost sounds like they're breathing through a tube, right? Like a straw. Is it? So you have expiratory wheezing? And you're supposed to be wearing CPAP, right? Yeah. All right, diminished. If a patient has pneumonia, if they have a collapsed lung, they will have diminished lung sounds to the left or the right. It is just determined we're going to do plural rub.
I'm a teacher just like you. I teach 6th grade science, and if you're anything like
Not
me,
just like
you
me.
can hear me in my enjoyment lines.
In this video, we're going to discuss diminished breath sounds. And the key thing to remember here is that there's a variety of reasons why someone can be displaying diminished breath sounds in constipation. Chronic conditions like exacerbations of emphysema, heart failure, even some advanced stages of PD. And then look also for the more acute things that can be going on, which will be mostly told by your mechanism of injury if there is one, or the disease process that the patient's experiencing, such as pneumothorax, pleural effusion, anything that's going to display air or fluid in or around the lungs.
So it sounds different than the bronchial, right? The bronchial was full, and where this is short, shallow, right? All right, stridor is a lower airway problem. This is if they've got something.
We're going to review the expiratory wheezing lung sound. Typically,
They've got something that's packed down in their airway for whatever reason. Kids with croup. Croup is a lower airway.
Stridor is a scary sound that is indicative of a severely narrowed or obstructed airway. It is most often in the upper airway and often needs rapid.
We're going fine. Mm-hmm. All right, there it goes. Here.
Stridor is a scary sound that is indicative of a severely narrowed or obstructed airway. It is most often in the upper airway and often needs rapid medical intervention.
Or a whistle.
Now, where are you listening to that from?
From the lungs.
So normal.
Specific conditions that can cause stridor: epiglottitis, croup, foreign body airway obstruction, or anaphylaxis.
The stridor. Did you have a name for it before?
No, I just knew to listen to him when he took it.
Yeah. Oh, that's right. Yeah. On Elizabeth Road. He's such a sweet guy. He's like, yeah, I can walk through the car before we got there. I'm like, we gave him that updraft treatment. He was just fine. Yeah. Huh? Yeah. Yeah, it'll make you jittery. Increases that heart rate. So that's another thing too. If you've got a patient with a fast heart rate, you got to give, you're looking at giving them a treatment, and you think,
During school, I went with Ernest for student loans. I was able to pick up my rates.
one thing that albuterol does is it increases the heart rate because it's trying to expand those blood vessels. So the heart's going to try to pump as much blood as what it can. And if they're already high strung, they can't breathe right. So that's going to increase the adrenaline. So that respiratory drive is trying to kick in, right? More blood flow, more oxygen. Don't worry about not giving it. Give it anyway. You're not going to increase that pulse to a point where they're going to pass out or their heart's going to explode. Again, What's gonna kill them first? Not breathing or fast heart rate.
We're going to discuss the bronchi lung sound, which is typically a low-pitched wheeze, is one way it's described, and it's going to be caused by some sort of secretion or fluid, typically in the lower airway. Things that can cause bronchi are COPD, pneumonia, chronic bronchitis, cystic fibrosis, and the key thing to remember is that bronchi is often described as like a snoring sound, which kind of helps differentiate the way we describe it when we're reporting what we've heard on auscultation.
So this isn't actual snoring respirations. This is what you're hearing on the inside that it sounds like snoring. Sounds like he's underwater, right?
It can be, yeah. What he was talking about, the cystic fibrosis, that's just a hardening of the
And this
lungs.
lung sound video we're going to discuss strainer.
It's just everything's getting too hard. Huh? Yeah.
Crackles are indicative of inflammation or infection of the small bronchi, bronchioles, and alveoli, which can cause increased fluid in the lungs. They can be described as either fine or coarse.
So how I remember the term crackles is firecracker. It kind of sounds like
Specific conditions that can
firecrackers going
cause
off,
this inflammation
multiple
include pneumonia, pulmonary
multiple
fibrosis,
firecrackers going off in
acute
a short time.
bronchitis, CHF, or acute respiratory distress syndrome.
Meet Grammarly Go, your go-to solution for getting quality work done quickly.
All right, last one, we'll take a break. Now we're doing plural rub. The one that's asked us 52 times. Where's my button?
Pleural rub is the name given for pleuritic lung sounds that are heard on auscultation. This occurs when the pleural surfaces are inflamed and rubbed together, producing a grating sound, like two pieces of sandpaper.
So this is also some hardening. Hardening of the bronchioles, the alveoli.
Specific conditions that can cause pleural rubs include pneumonia, pulmonary embolism, rib fracture / trauma, tuberculosis, infections, and pleurisy.
All right, we'll break. We'll meet here 15 after. Plural. Yeah, sometimes crackles. It depends on where it was at and how long it had been before they had actually gotten help. So these are wheezing. Of course, there's different stages. So your regular bronchial sounds is going to be your first stage, and then like your second stage is your wheezing. The more that it gets down into the lungs, like the stridor is a lower lung, so it's going to be more of a fourth, fifth stage of lung capacity injury. So while you guys are finishing up, we're going to go over just a few more videos here. So we listened to the lung sounds, but we're going to see where we're. Yeah.
Should have took that then.
Do what? Yeah.
Hey, so we got all of you just for hands-on.
Yeah, we'll
Load up. Everybody just steps up.
So, I told him to go back to 8. You go ahead and copy page.
Oh dear.
Oh dear. So what? Yeah, she would have. Okay, so what I've got pulled up here, you're already recording. I can edit this later, so it's not a big deal. I'm going over the auscultation, ventilation, in the BVM practical. When you go over the BVM practical, here are the sheets to go over. And there's also, I'll pull up the game. We have another Jeopardy game. You want to switch around?
Okay.
So it'll be vital signs. Ignore this one. It'll be vital signs. Yeah. You'll have to pick out the little butterflies and stuff. It'll ask you how many teams and whatnot. So, in the event that I'm not back by that time, because these are the cheat sheets, this is the respiratory. Yeah, everybody gets one after the game. So we should be back by then. All right. You're in good hands. They're nervous. Play the video.
I don't even know how she was playing the video. Y'all, please bear with us. And if you have a medical question over something, write
We'll
it
make it
down.
up.
If you want the correct answer, write it down, okay? Because I have a really bad habit of just answering the first thing that comes off my head, and it's usually a smart ass remark. So it's probably not gonna be the right
She'll
answer.
keep that video for you.
So. It probably is, but this is the way she's doing it, so there was a reason why she was doing it. I know, I don't know. Oh, it's up here. Okay.
Can you reach it?
I hate working this way. All right, Sam, we're gonna need the internet here. There it goes. This is not what I was doing, was it?
When auscultating lung sounds, ask the
No,
patient
that
to
ain't
move
right.
in
We done that
or
first.
rehab.
Yeah, it is. I think it is.
That's the first video.
Yeah, but I don't think you went to different.
We're gonna watch it anyway.
For each auscultation point, start just above the clavicle to measure the apex of each lung. Move down to the upper lungs. Then to the middle lobe of the right lung
Fit your
and
way.
the upper lobe of the left lung.
You've seen it.
We finish by auscultating the lower lobes of each lung. On the posterior side, auscultate the apex of each lung just above the scapula. Move midline, avoiding auscultation over the scapula as you listen to the upper lobes. Work your way down the lower lobes of each lung, remembering to auscultate the right and left lung before moving to the next auscultation point.
Most people have no clue that in 2023,
Listen,
the
Billy
best
Bob.
way to make money on Amazon is not with physical products. It's Amazon's other company.
I'm glad she can edit these. That ain't it. Oh, is it? Well, was it? Oh, osculation. Okay, so we was on the right one. Maybe copy hyperlink.
Just click, I just double click on it.
Yeah, but if, hang on. Yeah, well, I don't think it'll play from here. Copy hyperlink. Open here. Tap in here. Paste. That's what. Enter. Crepitus in my neck. Yeah.
Okay, guys, now we're going to talk about hyperventilation, proper ventilation of the patient. Think of the last time you went on a cardiac arrest or an RSI, and after the patient's intubated or when you're bag valve masking them, you're doing it way too fast. So that's what this looks like. Look how that lung just keeps inflating. And that's not good. That increases interthoracic pressure, decreases preload, decreases stroke volume. And it's really bad for the restricted lung patients because they don't have time to exhale and they have all that air trapping. So what I want you guys to think about next time is just doing it once every 6 seconds with one hand, hold it like a football, just using those fingers.
I think what happened. No, I think she double did that one.
Yeah, we've all those videos we've already seen.
Oh my gosh, I'm doing this left-handed, y'all. Please do not judge. I can't see what I'm looking at.
Okay. You hit it perfect.
Welcome to EMTprep.com. This is the bag valve mask ventilation of an apneic patient skill. Before we get started, I would like to discuss some of the key points to ensure your success. The candidate must first take or verbalize appropriate body substance isolation precautions. Check responsiveness and breathing. And request additional EMS assistance. Checks the pulse for at least 5 seconds, but no more than 10 seconds, and opens the airway properly. Prepares a rigid suction catheter and turns on the power to the suction device or utilizes a manual suction device. Inserts the rigid suction catheter without applying suction and suctions the mouth and oral pharynx. Opens the airway manually and inserts an oral pharyngeal airway.
ventilates the patient immediately using a bag valve mask device without attaching the oxygen. Rechecks the pulse for at least 5 seconds, but no more than 10 seconds, and attaches the bag valve mask assembly, including the mask, the bag, and the reservoir, and supplies oxygen to at least 15 liters per minute. Ventilates the patient adequately, providing proper volume to make the chest rise at a rate of 10 to 12 breaths per minute, but not to exceed 12 breaths per minute. Let's watch in real time as the candidate performs the necessary steps to bag valve mask ventilation of an apneic patient.
This skill is designed to evaluate your ability to provide immediate and aggressive ventilatory assistance to an apneic adult patient who has no other associated injuries. This is a non-trauma situation, and surgical precautions are not necessary. You are required to demonstrate sequentially all procedures you would perform, from simple maneuvers, suctioning, adjuncts, and ventilation with the BVM. You must actually ventilate the mannequin for at least 1 minute with each adjunct and procedure utilized. I will serve as your trained assistant and will be interacting with you throughout this skill. I will correctly carry out your orders upon your direction. You may take this time to familiarize yourself with your equipment.
BSI, is my scene safe?
Your scene is safe.
All right, so I'm gonna check my patient for responsiveness and for breathing. Sir.
The patient is unresponsive and apneic.
All right, so I'm gonna request additional EMS resources and I'm gonna check for a pulse. Do I have a pulse?
You palpate a weak carotid pulse at a rate of 64 beats per minute.
Okay, at this point, I will open my patient's airway.
The mouth is full of secretions and vomits.
All right, I'm going to suction the airway. I'm gonna prepare my suction catheter, turn my suction unit on, insert without suction applied, and then apply suction, sweeping the mouth as I come out.
The mouth and oropharynx are cleared.
All right, so now I'm gonna open the airway manually again, and I'm going to insert an OPA. Does the patient accept the OPA?
No gag reflex is present.
All right, now I will begin ventilating my patient with the BVM at a rate of 10 to 12 breaths per minute. And I'm also gonna recheck to see if I have a carotid pulse. Do I still have a carotid pulse?
You still have a carotid pulse.
Okay.
The breaths are going in without difficulty.
All right. At this point, I will attach my BVM to high flow O2. Get that attached and turn my regulator on. And continue ventilating my patient.
How would you know if you are delivering the appropriate volumes with each ventilation?
I would look for equal chest rise and fall and an adequate amount of chest rise and fall.
Is there anything else you'd like to do?
Nope, that's it.
Okay, thank you.
I mean, when you sit there for a minute, how do you get that easy? I can look at that.
Well, you're doing once every 6 seconds.
So whenever you're doing that, you do it enough.
Be quiet, woman. No, I'm talking to her.
But when you're doing it enough, you'll know kind of like,
Every 6 seconds, that'd be
you'll watch the test drive and you'll know.
So, I mean, it ain't
You'll have to
exactly
watch it a lot.
6
It's not
seconds.
anything false. Let's say your respiration is 4 per 15 seconds. You time that up. 4, makes it 16.
Right. Kind of like, so take a pulse for 15 seconds at a time before. A minute.
I mean, it's that way, but it's like I can go on scene and watch somebody and I go, they have respiration for it, because I've seen it. Which when you get used to it, you'll kind of know what's too high, what's too low. Or he was getting in depth with 64.
Well, and I went and assisted the EMT program a month and a half ago at ASU Mountain Home. My wife's an adjunct teacher there, so anytime they have something like that, y'all's mass casualty events y'all have. They're always looking for patients. And they're gonna assign you a spot and say, this is what you're gonna do to test first responders, paramedics, EMTs. So they put me in a situation where I was a seizure patient and told me, as soon as they offer you some type of air, whether it's BVM or whether it's O2, you can stop seizing and go lethargic. And so we had 7 students go through that scenario. So that's exactly how they would do that. If they were doing their practicals, they would come in and they'd say, okay, here's our situation. And they'd say, okay, I'm gonna take blood pressure, and they just touch your arm like they would do blood pressure. And then the proctor would tell you, this is their blood pressure. And so they're answering the questions the EMT is asking them, but they don't volunteer those. He's got to do his job. You're answering the questions rather than him actually getting his stethoscope out and listening, or getting his blood pressure cuff out and listening. So this is pretty much just a proctor. This guy may be going through EMT school and he's fixed, graduate, fixed tech test. So this is a scenario that's normal in situations like that. Normally they're not quite as hands-on. Normally you don't have all that equipment, or if you did the BVM, you just lay it and say, hey, I'm giving 6 seconds, once every 6 seconds, and the proctor would accept that and move to the next. So that's normal when you're, and here's something else, folks. If you got a night, and I know it's tough, everybody's working, everybody's fire department meeting, and got PTA, and kids got soccer. If you get the opportunity to be a patient, go up there. I didn't realize until that scenario that when you're having seizures, you're not breathing. I didn't know that. I dealt with a woman that I was married to 23 years. The last 10 of them, she had seizures. And in that 10 years, I did not know that when she's having seizures, she was breathing. So you pick up something, and I got free pizza. So, what more could you ask for? They didn't offer any beer, but they did offer pizza. So. Oh, I got 72 pages open.
Yeah, that got me.
It ain't that.
They're pretty good. Is that it? Is that all?
Yeah, that was all of them. The question is where did there it is. Yeah, that one. Here, I'll be there. You forgot the game.
Over the James last year when they had that mass casualty, our fire department had some kind of other training going on.
I don't know.
The first one they had set up, and then
I guess some respiratory.
On the first one, I was supposed to. And then I think they do the way I had to work.
There's no questions.
No question.
It says there's no questions. We're doing respiratory, right? That's what she said? Respiratory?
No, skip respiratory, go to vital.
Do vital?
Yeah.
Okay.
She said skip.
Okay. Well, good thing you're listening to her. Cause I love it. I'm gonna use it.
Oh.
You good?
Ready? This is a cheat sheet on the respiration stuff. I believe is what she said it was. Yeah. Oh, no.
This is how to properly administer oxygen. So this is what they would go by if they were testing
It's a cheat sheet. You have to do this? No, break your arm. That's what I said about the door. It's about it. So what we're saying is when you take that proctor test, this is what you need to go by. Regardless of what's said in this room, these are the answers to those questions. The fire captain says this, but this is what we do, skip what we do. This is what that test wants to know. If you go by your fire department protocols, you may flunk your test. Right. So with that book and these notes she gives you are to help you answer the question.
So like this is for, are they going to observe us actually doing it?
No.
Okay.
Not what's changed.
Okay, thank you.
Did they still do practice?
He said
Well, that's
no.
what this is
He said
for.
no.
He said they did 50-part question test and then he will watch everybody kind of do it in class.
Well, I asked me that when we get back because we had practice. They set up us 9 different stations.
Yeah, that's what
He
this
said
is
they
for,
don't.
so that's what I was asking.
He said
We
they
had
don't do that.
And what scared me is when you get to trauma, and this class is being taught different than, I did this 6 years ago,
8
8 years ago.
8 years ago.
And that was the class together, so. And so we had pretty extensive, and trauma was the last thing you learned, and it's the one that makes you hyperventilate, because you do this respiratory, you do this heart rate, you do this deal, trauma, you know. And so when you got your 9 stations or 8 or however it was, they draw a straw and say, you go to number 1, you go to number 2, then you go to, I got trauma first thing out of the fast.
And it's the lightest.
And got through it, and after that, everything's easy. I mean, it was walking partner today, because that was the one that you're going ready to work. And so,
And what he said, the BSI should say, this is not how you say it.
that was what I was talking to her about the other day. When they were working that scene after the electrical, and when they got done with it, I said, okay, number 1, BSI scene safe. Because when we did everything, you started gloves on, BSI, scene safe. That's the first thing coming out of your mouth before you did anything.
And you didn't say it like that. You had to say, gloves are on, BSI is my scene safe.
Yes, the question. And they were, yes, you could proceed. So.
If they said no, call us.
We'll call the cops.
You don't want, you know, say.
So, but I don't know how far they stress out. I don't know if they changed that or not.
He said they're not doing the practical, that you'll kind of watching Dave. Understood.
Well, that's what she was saying, we picked the wrong group, because when we did it.
You had to do it all.
Well,
that's a good thing. I mean.
Well, here's the deal, that they also experimented with thinking about doing. I think they changed back paramedic program. You go through, you learn all this. And now the majority of it is you do the work, footwork at home, you come in and do practical in the classroom. They were talking about after you graduate and they put you through the practicals, and that's part of your score, whether you pass or fail. Now they're talking about doing away completely with practice.
What?
Completely.
Oh,
Now,
or no.
they approached that, and I think they backed off of it. Because, you know, during COVID, nurses, that's going through nursing school and all that, well, okay, you hit your test, but we need you in the hospital. So, you know, they were pushing, truck drivers, 21-year-old or 18-year-old truck drivers and stuff, they were pushing through so quick because they needed them.
Well, nurses didn't get to do clinicals.
Yeah.
Clinicals were online during COVID. We didn't go into the hospitals and nursing homes.
Right.
Clinics and things.
So I think that was the mentality with the EMT and the paramedic program was, we've got this pandemic, we're just gonna get them to class and turn them loose. When you really do need those practices. And so that was, I think everybody screamed, what? And then went, oh, hold on a minute, let's back up off that, reconsider that just a little bit. So.
You could tell there's been a nurse that's had a practical and a nurse.
Right.
I was ready for a practical situation.
We hired 2 nurses. One that literally just graduated, has nothing, never worked anywhere, and one that was a CNA first and all that stuff, they're both RNs. I would not go to that one that just graduated somewhere else.
The whole style of our education system in these fields has changed a lot. It is scary. My 7 patients that I had up there in that practical, I started out on the first one. And like I said, they told me as soon as they offer oxygen, quit and go lethargic and just moan. And my first one, about 2 minutes. And I was, as we progressed, it got worse. They had me on a mattress on the floor in a closet. There was 4 of us in there. By the time I got to the 7th one, she didn't even touch me. And she said, so what's the blood pressure? The pressure is 120 over. What's the pulse? Pulse is 12 minutes. I laid there.
You're dead.
Fake season. And almost went beep. She had me loaded, and we were 5 minutes out from the hospital is where it happened. En route to the hospital, and she called in the report and they asked her what's your O2 levels. And that's when it hit her. After me laying there 12 minutes shaking. I got up the next morning and couldn't hardly walk. She never touched me. She never said, what's the blood pressure? What's the
And
pulse?
when we did our practical, you had to touch. You had to touch every part of what you were doing, make sure you knew what you were doing.
So it's a whole different world out there in the education system. Yeah. Right. When
Oh,
we,
y'all can see our pictures. You would.
when you went through, put people on the backboard, that was one of our practicals we had to do. They teach you to roll the person to you, and the backboard goes in behind it. 9 out of 10 people did exactly the opposite. And that's why that person's there watching. We were physical. We strapped people to backboards with spider straps that keep them upside down. I mean, that's to the extent we went to. Yeah. When we loaded in an ambulance, we loaded in an ambulance. I mean, that's how practical we were with it. So.
And we were looking up that day, we got our practicals, survival flight came down and we got to load somebody up into.
Yeah, we've got a really cool picture of our ship suit set directly right in the middle underneath the helicopter. So.
You ready for this? Who wants to be an onion?
Onion, who's onion? They want to be the onion.
Should go back 4, 3, 2, 1?
Yeah.
Okay.
I think one or two of the groups missed out.
How do you? Nope. Okay. No, I don't know how to do this, so this might be interesting.
No. Unfortunately, you're by yourself. So one, 2, 3, 4 groups.
Yeah.
So is check marks in the corner. What do they do?
Change the name.
Oh.
So I can just.
Do we want to type like table 2? Okay. Table 1, you're in orange.
You don't get a choice.
We're gonna give you the choice. We're just gonna do it. Who we got left?
3 and 4.
Watermelon. Wait, somebody needs to be a watermelon. That's gonna be table 3. 3 is gonna be a watermelon.
I'm doing a potato.
Okay, potato. Number 4 can be the potato. Okay. So we don't, do we even need the others? So
I did it backwards.
that's all right.
Oh. So how do we decide who gets to go? Who?
Well, it's not her. She's being aggressive. So she don't get to go first. Okay. Okay. You want to just do,
They won.
hey, we forgot the sideline group over there. Anyway,
They don't count.
they don't count?
They
Okay.
don't count.
I wasn't here when y'all played it last time, so I got a clue.
We just went like this.
Okay. So we're on table one, pick a category.
Go for it. Can you see it though? Okay. Stand above it.
Yep, of course.
What do y'all feel comfortable with?
All right, so we're gonna let, we can't put the order. We're just gonna let table one, pick a category, okay?
We agree, they were in the negative last time, it's okay.
Lung sounds?
Vital sounds, 400.
Lung sounds.
Oh, lung sounds.
100.
All right, are we ready?
You watching?
I'm watching.
Okay, so I'm gonna go with you, bro.
Oh, right here.
Hold on. Turn the music off, sorry.
Do we have?
Strider?
I don't know why this one.
How do you go under this one?
Do you hit the check mark under the
yellow answer.
Hold on, too far away.
minute?
We subtracting points this time?
Yes.
Sorry, which table was that? Answer.
Number two.
Okay. Everyone knows again.
Okay. Well, I heard them. Okay. Okay, back in the bag. Table number 4.
It's on table 4. I think we usually have to.
What?
We.
Wheezy? Okay. There we go.
Oh, no, wait.
So are you gonna help them?
They're the frat boys, they're over there doing their own thing.
They're the ones that fought.
Okay, table 4, what you want?
We'll do signs and symptoms for 100.
Signs and symptoms for 100.
No,
Oh.
signs or symptoms.
It's a symptom.
Final answer?
Symptom.
How many was that, 400? It's,
Yeah.
now I understand why she's. Now I can see it.
That would be a wrong answer.
Okay, what do y'all want?
Oh, yeah.
Respiratory. 15. 10 to 15.
Yeah, 15. 200?
Yep.
Oh, that.
What are we the onions?
Your potatoes.
Well, they both say closer, so how much is closer?
200, pulse rate 200.
Pulse rate 200.
Way back.
I'm gonna say, 94.
94, they said. It's in the range.
What did it ask for?
It was the pulse rate. He said 94, so I mean, yeah, he's correct. It's just.
So obviously, all of those in that category are probably in the range.
That's what I'm thinking. That's what I'm thinking.
So did we get that order?
Yeah, we gave it to
Well,
you.
let's have, for now, try and stay in your ranges. 200.
Are you cheating? I don't trust him. Zach.
What if you just do a game of
All right, where's your next category?
Let's do,
Whoa.
Sounds for 300.
Is this supposed to be a true or false?
I don't think so.
Wait.
You know it? Number 4.
Dang, can't remember the name of it. Bronchioli, when it gets infected, it has the problems and crackle or pop. I can't think of it, that's why I need y'all.
I think they're looking for more of a medical term there, because it's actually also those crackles.
Yeah, that's what I'm asking, for medical.
what is the state?
Okay, now hold on.
10 seconds.
Time's up. So it's open for the other 3 tables.
What you want?
You said what?
The sailors, what is the last one? Sailor?
Stater?
Strider.
Try to say-
How much you got for 300? Nice.
Okay, y'all were actually going to pick last.
Yep.
And missed it, so. I think you got a question for that, wasn't it? Okay, we got one for that. Yeah, okay, wait a second.
You take this time. Whatever y'all pick. Signs and symptoms for what? Signs and symptoms, 300.
I heard this one first.
And I cannot get to that.
Good.
We gotta wait for her. How much was it for? 300?
What's the name of
Symptom.
Yes. It's table 3, right?
Yes.
She's pretty quick. She's in there, but she's ready.
Oh.
See, sometimes if you give them enough time to think themselves.
Can we let him do it this time?
Okay.
That's one question on that.
Huh?
Got an answer, to sign or symptoms of shortness of breath. You could see your shortness of breath, so it wouldn't be a sign. But they complain of shortness of breath. It also be a symptom.
Good. I think they go by.
What they say. Okay, so since we're so deep into this, and right now, category of questions. Okay.
Who's got the better eyes?
Oh,
you're right. Hold on, whoa, whoa.
Average blood pressure.
Average blood pressure per 100.
Okay, ready? Y'all better. Table 2 for 100.
All right, y'all pick the next
Average blood pressure. For 200.
one.
It's got in the back.
Nine. You say what?
No,
he said it. Go ahead.
97.
Okay, it's only asking for one side.
Yeah,
Okay. Is it not only? I'm not reading them. I'm trying to.
What are the average systolic?
So I thought it was the whole blood pressure.
Okay, so 97. Nope. That one is like a very.
So y'all pick the next one. Did you? Okay, go ahead. Respiratory intervention for 100.
Everybody's scared of this one. Oh, maybe that's why.
So, buddy.
I don't know. Can I take a
The
guess?
A and the O is backwards. That's the first breath of air.
Well, I was gonna go. I mean, I can have a guess.
Yes.
Full breath, airway open. I don't know. I got one right. Okay. So nobody got that one. We're gonna let that one go. Respiratory intervention for 200. Exactly. Is that a question? Reposition the head and assist with an adjunct.
So are they wanting us to tell you if it's an OPA or an
I
NPA?
think that's what they're wanting.
So is one or the other?
That's what I'm thinking.
We're gonna say.
Yeah, we think that's it.
Oh, sure. Oh, yeah. I'm not taking away on that. That was too hard.
Respirations for what?
500.
500.
Go for it.
Go home.
Ooh, infant, keyword infant.
Oh, right here.
I wanna say 60 to 80.
Final answer? Respiratory.
But she already said it.
You did.
34.
34.
Yeah.
Good guess. All right.
Just pick one.
Okay, respiration 300. I mean, I guess not.
Don't get this one wrong.
18.
18.
Oh, 300.
Yeah. You hear that anyway.
Yeah. Pulse rate's 300. Yeah.
Pulse rate's 300. Oh, in the back.
That's when we talk about the ancestral blood range.
Yeah.
Yeah. So how much is that? 300.
What's low and what's high?
Yeah.
Yeah.
So we'll take, call for.
You're very glad.
Blue.
So I want to tell y'all, we're probably letting y'all beat my wife is straight up the hammer.
Yeah, you should be with 60.
She
think you do that
Yeah.
Well, she probably wrote this, so she probably knew.
We're gonna have to know that 60 to 100.
Oh,
80's not gonna work.
Oh, the test will ask you, is that 84 an average pulse rate for an adult? True or false?
Yeah.
And you'll say true, and then you go to the next question. What's a good pulse rate for an adult? 84, 72, 102, 65?
You have to choose the best route.
Exactly.
All right.
They're out at the ER.
Average blood pressure.
Oh, in the back.
I just decided he just doesn't see right. What do you say?
Yeah.
120. Yeah, 160 and 180. We'll do it.
Systolic only.
Systolic only. So the bottom number there?
That's the top
No. Oh, is that top number? Okay.
We're great teachers, let me tell you.
Nice call.
Yeah, 170.
Say with what? 120. 120.
Nope.
Oh, you're out.
Okay, y'all pick. Y'all pick that one? Okay.
Pulse rate's 100.
Oh, right here, number 2.
60 to 80.
Yeah.
I was like really far.
So 400.
All right. All right. Hold on.
I'm just curious.
What's the score? Number 4's got 100. Number 3's got 5.
500.
2's got 2. And number 1 is 300 in the hole.
Are you ready?
Right here.
130 to 210.
Well. Dang.
Good job.
210's too high. 210's too high.
Yeah, 210's too high.
Well, he got the
Half of it was in range.
So we can do half point. Well, I can't do 50s. I can do a half point.
Can we do it?
Well, I can do 200, 300.
I don't think Jeffrey has that point.
Well, I think you win, you lose. You know, I think that's the way that one goes. You get it right, you don't.
I'm getting 200. Sorry.
No soup for you.
No. Okay.
doesn't really matter. We gotta answer all.
What was it? Love sounds for 4 minutes.
Wheezing. Not wheezing. We already heard that one.
Okay, hold on. Say this. You were the next one, right? Okay, wheezing is yours. We'll let her pick, and we'll find out. We'll see who's points. Huh? You're gonna go with wheezing.
Table 1, tap 2.
Come on.
I'm not confident with my answer. You gotta give them a chance.
Okay.
What's table 1's answer? Because he tapped 2.
You get their points? Well, I had this one answered.
Wheezing, Strider.
You had
Do y'all-
one answer while I had three.
And what about table 1? Yeah, table 1, they all tapped the same time. Y'all don't know? So Wheezing and Strider was 2 answers?
Yep.
Yeah. Ignore it.
All right.
Takes a second. Okay.
I know the name, it's not rendering. Oh my gosh.
If I give you the word snoring.
Yeah.
You'll say snoring. Okay. That's all when I asked that anyway, so.
See, I know that.
So that was table 2.
Restorations for 4. Oh, right here.
I want to say 12.
And. Don't pay no attention to peanut gallery. Well, this one. That's it.
12 was in range, though.
Yeah.
Only get half. There's 12 to 20 is in it.
All right, so.
We're out.
Restoration for 100. Oh,
Yes.
3 here.
36. 36.
There we go.
No, what happened to me in 1 meter?
How much is that?
No, you speak. Mom, you're old enough.
I don't know.
Guess who's walking though?
Normally, if you run out of oxygen, your ambulance will help you out of that. Or your fire chief has been arranged with someone. Don't.
What do you think those people at home that are on one? If our doctor sends you home with one, they pretty much put you on hospice. At our clinic.
All right.
What do you want?
Blood pressure, 4. Yeah, I'm gonna say 90.
90 size up. No.
I think we're winning. Oh, no, we're not.
500.
500 for what? Okay. Whoa, keep pushing it down.
Oh, right here. $140.
No.
So you all pick the last one. Pick one.
We got 300, 400, 500.
3, 4, 5, 3, 4, 5. 400. 400. Come on, there we go. Wheezing? Hold on.
Oh, sorry.
There's an official wheeze, and then there's one that has to sit.
They're fine.
500.
Okay. This is a good question.
60 millimeters.
21%.
And he gave me different answers than that.
No. We'll find out here. We'll figure out. Now, what did you answer?
The pressure. I was on the pressure.
Okay.
I.
What did you say?
Wait. Well, now what I was doing was there's a.
Like it hangs pretty close together.
And so when they answered, she gave me the information, so I just we'll see who comes out with it.
Okay, last question. Well, not last question, but
How much will make it do those?
Yeah.
is that 4? Hey.
Okay.
So only 2 people can wager.
All right, only 2 can wager. It's table what, 2 and 3?
But we'll do kind of like we did last time. If the negatives gets it, they win. Nope.
How did you do last time? Everyone can make a wager?
Everyone can make a wager.
Okay.
If you're negative, it'll let me.
Okay.
So, okay. You can wager zero. Okay. So potatoes have 200, which is table 4. Table 3 has 1200. Table 2 has negative 700, and orange has negative 300.
So if you're in, okay, how about this? If you're in the negative, you can only wager what's negative. Okay?
Oh, I see.
Make you 0.
All right?
Okay.
So table 1 is what? 300.
Negative 300.
300. So y'all can wager up to 300. Oh, yeah, sorry. They're backwards in front of me. Okay. So y'all wager up to 300. Go all the way? All right, number 2. What are they? Negative 6? 7?
7.
All of it. So you can wager up to 7. All right? 3 is 1200.
Yes.
200.
200. They're gonna wager 200.
Can we wager 14-1? 1401?
You only have 200.
You only got 200 to work with.
Are you gonna wager all?
Well, yeah, I have to.
I'm gonna see if it's elevated.
The table 4 or 3.
I was just trying to see. Okay. All right, so is it male or female?
I'm just waiting for somebody to start counting.
On both sides?
I'm guessing, I figure probably so.
So y'all come back.
Oh, my broke, I know that.
Right down.
Right now, piece of paper, fold it over. There you go. Ten, 9, 8, 7, 6, 5, 4, 3. Okay, are we ready?
No.
Unfortunately, it's time.
Man. Okay, everybody's got the same answer.
Well, right. The picture's the right. Well, okay. Everybody get it right?
Yeah, everybody got it right.
So. 0, 0.
What they
They
did?
only wait for
200.
All right, y'all take a quick break. They're on the way back to the hospital. So she should be back. She needs to be, so y'all take a break. Pee, whatever you do. Huh? Oh, right. These guys they need to be their own team. Right.
I got 22. I love you, by the way. Yeah, I do. Still. You're still walking home. Okay, right, you go on. I'll turn his baby inside out and go walking. Longer walks if you want to walk. See, typically I would let you, you could say that I was walking, but I tried today. Sorry, I really don't. So where do you go? I went to bed for a while. You know what I'm saying? I'm here. You like it yet? They don't want hot out there. Good luck when you need to. English. Good luck. Major good luck. Salem's a good district. One of those school districts around.
A good school district, I guess.
I've taught at Highland for 15 years. But I'm looking forward to changing that.
When is the school coming back?
They have good academics.
Did they ask? I mean, did they put me out? Like, I still have my account. Log in. So I was like, kick me out. I'll have to email them. Like, hey, yo. It's important for yourself to be all in. Hey, yo, I don't know about my life.
Well, that's kind of that's the village. So if you will go and look where they spend their money, they'll help you decide if you want to go from there. Go look it up.
Do you want your pencil back?
I mean,
Yeah, they have to give you a $2,000 raise. But you'll never see another raise again. I mean, so education, higher education is pointless. Yeah. Why would you do that? I would never recommend anybody go into education. That's what I said.
You get a raise if you like go get your master's, don't you, from a
You
bachelor,
used to.
but you don't anymore?
Well,
Not
not
with
this
the way,
new
not
law
with this
coming
new
in.
Learns Act.
So a brand new teacher can come in. If she's been a teacher for 15 years, like I was a teacher, they're gonna be making the same amount of money as us.
Because
With no
experience means nothing to these people who pass this act. And they point blank said, experience doesn't mean anything.
But it's because there's a teacher shortage and they, you know, the school
Somebody
district,
is start
school districts for years have received $74,000 per teacher for years. But it's never went to the teachers. It's always used for coaches, additional administrators, never for the teachers. But that's what the state gives them every year and they have for, I can't take years. But the, you know, a lot of the schools around here, the starting teacher salary was $32,500 until this next year. And that's the reason nobody wants to go.
40,000.
Well, they just went to 50, but it was 32.5. I actually think the law was like 28 something, wasn't it 28.5?
No, I think when I first started teaching, 15 years ago, when I first started teaching, Holland was at 30.
That was not state law.
No,
They
that
were
was
higher.
above state law, so
Just
it
barely.
was.
But I think it was 28.5.
It's good, maybe, sort of, if they have restrictions on it. But what about the people that have been in service for,
That's what we're saying. They got no raise out of this. It really hurt them.
you know, mine's right there in that category. Well, since 95, she's been teaching 41 years, she's been here since 95.
Yeah. And it's going fair to her.
She's the elementary,
No, I just tripped it
she's
out.
the
I'm so
elementary
sorry.
counselor at Salem.
I
Vicky.
did not mean to put the
Rosito.
video on.
See how unfair that is to her.
So, you
I mean,
know,
that's why.
she's just a couple of years at 52, 53 days. And all of a sudden, any kid can get started at 50,000.
Yeah,
And
so-
she has,
so me too.
every one of her licenses.
8 o'clock is usually my bed.
I have a specialist degree, and I'm gonna be making $2,000 more dollars than I can do starting teaching this year.
That's about what she's making.
Yes, so a starting teacher technically got $18,000 raise and she got all.
They're trying, but they're.
And he did tell me when he hired me that next year they'll look at raising on the far end and, you know, to make that more equitable. Because, you know, the money's gotta come from somewhere too.
Yeah.
So where's the money gonna come from?
Yeah.
I always say teachers and police officers are way.
Yeah.
Want you to stand out there on the
With-
side of the road in the rain.
What else scholarships are there?
So what did you do?
So I think we discussed last week that the state will send you, there's also the Pell Grant you apply for. And the school actually has several that you can apply for through there. When you go and you talk to administration, admissions and with financial aid, they can help you find stuff.
I'm wanting to try to get that.
Yeah. Well, your first thing would be to fill out your FAFSA. Yeah. Do you know how to do FAFSA? Okay, so she can show you like where to go and it's pretty lengthy. You haven't filed taxes yet, so you'll be going off of her taxes, so you'll have to get her information. Yeah. You're welcome. What's that? Said what? Yeah. EMT, it depends on if you want to go through the year-long class or if you want to do the semester class. Semester class, of course, is a semester, year is a year. And then your paramedic will be another year. So, and they recommend, some people, they go through the EMT. We had a student that went through, he thought it would interest him. He was 17 and he got through it and realized it wasn't for him. And his mom and dad made him stay in the class until the end of the semester. And he already knew, you know, so it's recommended that once you get your EMT, get on the ambulance for at least a year. It used to be 3 years, but it's like short staff is what we are. Within a year, you'll know if it's something that you want to go on. Because it'd be terrible to be on your first day of the job and you've put all this work and this effort into it and just feel like, but I can't do this anymore. So. Yeah. Yeah. There was a guy that went through the class, highly intelligent, very book smart. He went through it, and when he got onto the ambulance, he was there for about 6 months, and he was like, I don't want to do this. Or no, excuse me, 3 months. It was less than that. And he walked out on a shift. So it's not for everybody. So here is the Facebook page. Fulton County EMS. It's got our little truck logo there. It's on YouTube, yes. Yes. Well, I don't want to, somebody probably don't want their picture on there. Yeah. When our our department training, when I asked people, you know, to do it, we would report it. They were like, and so I had to do closed circuit on that. So on my end, there's actually, I got a couple playlists on there, and you have to have the YouTube link to actually look at it. Yeah, this is open though. So also I have up here Kahoot. Next week, if we're not doing Jeopardy, we're doing Kahoot. So you need to download that onto your cell phone. It's in the App Store, huh? The code? Okay, that's fine. Yeah. Okay. Yeah. Yeah. Yeah.
Well,
okay. What's that? Observe, sure. Yeah. Yeah. We got a little bit more we're gonna do. At the App Store on your phone. Yeah. So we have concentrated a lot on respirations. We'll work on blood pressures. We didn't really get to do a whole lot with that tonight. So we'll be sure to make some time to do that next week. Tonight was medical night. Of course, with stroke, your respiratory, that's high priority. Heart attack, also respiratory is high priority. Most with cardiac, we've talked about on the sample history. Do we remember what that is? So, S, what does it stand for? Signs and symptoms. A is not abrasion. Okay. M, meds. Past pertinent history. Good. Events leading up to. So we've kind of talked about heart attacks. We've talked about what were you doing, last oral intake, medications that they're on. So we've pretty much covered cardiac for that. Hanging out in the parking lot, guys. All right, so assisted medications. There are medications that you can assist with. We're gonna kind of go through these. I'm also going to pass out, did y'all pass out BVM? Okay, so we've also got oxygen administration. You got oxygen administration also? So you got both?
I handed out one, and then I handed out the sheet.
They're respiratory. Okay, so which one did they not get? We've got BVM ventilation.
What is it? What is it?
Okay, so BVM ventilation, yeah. I'm gonna also pass out, this is a cheat sheet. This isn't gonna be on the test. I had a student last semester ask for common medications, just to kind of painting a picture, right? Of what that patient, what's going on with that patient. So what I discussed last class about maybe sticking something in your EMR bag, this may be something good to just stick on the top or stick in a pocket that you can find and laminate it. It's yours, do whatever you want to with it, but it's classified common antibiotics, blood pressure medications, blood thinners, common beta blockers, which is heart medications and airway medications. And you'll see on here, some of the blood thinners has got parentheses and it's got another name. So medications have 3 names. They have a pharmacy name. They have basically the sale name with what it is on the shelf, and then it actually has, like, when it's created in the lab, that'll have a name with it too. But this is just to give you a general idea more of what you're dealing with. All right, assisted medications. These are medications that you're going to come into contact with. You're fine. You're fine. So oxygen, Narcan, activated charcoal, which really isn't used a lot anymore, but it is in your book. We don't carry activated charcoal anymore. Oral glucose, EpiPen, nitroaspirin, and albuterol. So oxygen, hypoxia, cardiac arrest, and central nervous system injuries. It's what's indicated for. You can give it orally, you can give nasally. Here's your dosages, 2 to 6, 15, 15. I can send it to you.
I think one of our different questions had that as a 10 to 15, which is a 15 to 15.
Okay.
So that may be some way to clarify this one test.
I'm going to pass out a piece of paper. If you want to write down your email legibly where I can read it, I will send you all of the hyperlinks that we're going over. I can send you the PowerPoint. So I was looking at the Jeopardy. I don't know if I can share that or not. I'll look because I log into my account. Like, you can go on there and make your own. I put those in there. Yeah, the Kahoot also was questions that I've pulled. Yeah. Yeah. For, huh? Yeah. Mm-mm. The videos is just on YouTube. Yeah. Yeah. Yeah.
And you could probably go into YouTube and type in that EMT prep and it would bring up all the videos that are offered.
Yeah. So again, activated charcoal is also known as Activase, the liquid char. It's for certain poisonings, certain overdoses. Always be alert in these always be alert with these patients, and always give it to alert patients, because they can choke if they are just alert to verbal. If they're going unconscious, again, you don't want them to aspirate. You give it orally. So adults is 25 to 50. Pediatric is half of that. It's 12.2 to 25 grams. And it's supposed to be within 2 hours of the of indigestion. Contraindications when not to give it to comatose patients. Don't pour it down their throat. Corrosive ingestions, caustics, or GI obstructions. So GI obstructions is gastrointestinal. They've got a block somewhere. So if they're not able to poop, you don't want to put anything more in there that they still can't poop. Oral glucose is for hypoglycemia. If you don't have a glucometer to check the blood sugar, go ahead. If they're alert, go ahead and give it. You're not going to increase it enough to hurt them. And it's short acting, so it'll raise their blood sugar up and then it'll drop down. So we've actually changed our medications. We have what's called D50, which is dextrose 50, and basically it's just like really, really thick hummingbird feeder water in a glass tube, and we just push it just as hard as what we can. But we're seeing where the patient, their blood sugar goes up and they're stabilized and then it comes back down. So we have changed to a more liquid form that's in an IV that is called D5. And it helps to, it'll bring the blood sugar up gradually and it'll keep them there longer. So
is that a straight injection into the system, or is that into something that
it's over like a 30-minute? Yeah. Yeah, drip. Yeah, thank you. So contraindications, hyperglycemia. Again, if you don't have a glucometer, you don't know what that is. If it is high blood sugar, you have access to that. Don't give it. Of course, no gag reflex. If they're gonna potentially aspirate on it whatsoever, don't give it. Yeah. Okay. Okay. Yeah. Yeah.
On the glucose, the one the other day, the basal meter is at high.
Yes.
I'm just curious what number does it go for?
I think it's 600. So I've never read one at 700. 600? Yeah. Yeah. There's a lady that lives out at Sturkey there at the big curb at Moco, and she's a large lady. She has an insulin pump. She's very, very young. I think she's in her 20s, and I've seen her at over 1,000. Yeah, combative, very, very combative. All right, so adult dosage is 1 tube. EpiPen for anaphylaxis. This is if they carry it on them. We had a child while we were at the children's home that is crazy story. Her mom, you get all kinds of stories, but mom said she was allergic to grapes and the color purple, and we had to be very, very careful about what we gave her, because a lot of barbecue sauces and stuff have grape juice in it. You wouldn't think that it would. That's kind of strange, but it does. And come to find out, she wasn't actually allergic to it. We had her tested for it, but she had an EpiPen. We had an EpiPen everywhere. We had one in her med box. We had one that she carried with her to school that the school nurse had. We had one in our vehicle.
Our first indication should be she's allergic to the color purple.
Yeah. Yeah. But until she got tested, that was what we had to do.
She's allergic boy was allergic to it. One of them was apricots and one of them was something else.
Whatever they didn't like.
Blueberries, I think. Yeah, fruit, pretty much. Yeah.
You guys grow allergies like that?
What's that?
You guys grow allergies?
Yeah, yeah. And some people too, yeah. I had a patient one time that they had, she had adopted this kid. It was somebody outside the family. It was a friend or something. She adopted this kid and it was great. I was wanting to give Tylenol to this kid and it was great flavored. And she kept telling me that he was allergic to it. And I said, well, how do you know that he's allergic to it? She said, well, because I'm allergic to it. I was like, but you're not related. And I couldn't get that through to her. So once we got in transport, I went ahead and gave it to him and he was fine. His fever broke by the time we got to the hospital, but yes. Yep. Yeah. Yeah.
No matter what.
So you give this IM or intramuscularly, you're going to put it into the thigh. There is, you gotta be careful with this too, because you can stab yourself with it. So you pop the top off of the end of it. The needle is in it. So once you get it up, you're going to get it in a meaty part of the body. You get it there and then you hit the button. But make sure when you take that off, not to put your finger on there because you can accidentally hit that button. And yeah, yeah, yeah. So then you have two patients. I had a student do it last semester. Yes. Yeah. That's not within an EMR's protocol, but on the ambulance, we're actually going to use what's called atropine. So, and they're getting away with that quite a bit. We don't use atropine as much as what we used to. So pediatric, 1 to 2 pins. If they have 2 pins and the one pin's not working, go ahead and give the second one. There's also pediatric size EpiPens. And if you have, say you have mom, she has an EpiPen, the kid gets stung by a bee, you know, mom has an allergy, don't hesitate to give the adult dose because what's going to kill them first. Yeah.
There's no way to modulate.
Yeah. Yeah. Safety first. Yep. Nitro, you're going to assist with this. It's for angina, which is just basically chest pain, but it's not like heart attack chest pain. Chest pain to acute coronary syndrome, which is a big word for premeditation to a heart attack. Pulmonary edema, that's when there's swelling in the fingers and the hands and the feet. Hypertensive crisis, high blood pressure. So basically what's happening is when you give the nitro, it's expanding those blood vessels in order for, say they have thick blood, they're not on blood thinners, but they need to be on blood thinners. So when you expand those blood vessels or they have a clot, that blood's going to be able to flow around that clot, or it's going to be able to create a bigger hole just to get the blood through generally. So it is short acting. You want to make sure that you take a blood pressure before and a blood pressure after to see where they're at. As with anything, when you check pulse rates, if you do any kind of intervention, you always check your what we'll talk about tomorrow is SMCs or PMSs, which is pulse motor sensory. And I remember that because I'm a woman. PMS, did you check PMS? SMCs is circulatory motor and sensation. So
Should you ask if they have an aneurysm before you do it?
To the nitro,
Yeah,
yeah, you can. Yeah, if there's if it's a brain aneurysm, I wouldn't worry about it. If it's what we call a hot belly or like an aneurysm, AAA in the abdomen, I wouldn't give it then. Aortic aneurysm. It's AAA, but I don't remember. Maybe. Is it? So you've got one. Okay.
Oh, yeah, go ahead and tell that. I forgot.
Anybody know what you're not supposed to take? Your child, natural, if they're taking something, certain something? Men should know this.
Yeah.
Taking a battery?
So contraindications here is right-sided MI. If you're not gonna know what side of a heart attack it's gonna be on. So if you give the nitro, you're not gonna be held up. Excuse me. You're gonna assist with the nitro. You're not gonna be held liable if it happened to be a right-sided. ED, erectile dysfunction drugs, if they have an allergy, which I've never known of anybody having an allergy to nitro. You don't give it if their blood sugar is severely low. In the event that you accidentally do it, just lay the patient down flat, raise their feet up.
So it brings blood pressure down.
It's opening those vessels up. So it's just a little bitty tablet. The tablet is 0.4 milligrams. It can be given every 3 to 5 minutes. Pulmonary edema, again, that's the swelling of the hands and feet. In a child, you're not going to give it. You're going to give it underneath the tongue, and that's because it's the quickest route other than rectal, going underneath the tongue to get it into the blood system. So aspirin, you'll get a lot of people that is on aspirin on a daily regimen, and it's 81 milligrams. We give up to 4 of those. So if you have somebody say, well, I take aspirin every day, okay, well, how many milligrams do you take? And say, well, let's take 4 more on top of that one, because it's not going to hurt them. All it's going to do is just thin the blood a little bit more, again, to make sure that the vessels, there's enough blood that's being pushed through to perfuse the core or the brain. Yeah. 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 So aspirin, ACS, acute coronary syndrome, which is leading up to chest pain and heart attack. You do not give it in active bleeding. The triple A's, rectal bleeding, esophageal bleeding. Use caution with patients with asthma. What's going to kill them first, the asthma or the heart attack at that point in time. Known allergy to aspirin, I do run into this quite a bit. Naproxen and ibuprofen, which are NSAIDs, that can have an effect to them. So here is just the 81 times 4, which is the 324. And I don't know why that our system is set up this way, but they're like, you're going to give 324 of aspirin. Well, if you do 81 times 4, it's actually 325. So I guess that 1 milligram gets lost somewhere. I don't know.
We lost that power.
Maybe. So PO is just post-oral. You're going to give that. They're going to chew it up. If it's got the coating on it, they're really not going to like it. I always tell them before I give it, I said, this is going to taste like chalk, orange chalk, because that's the kind that we got. Albuterol, this is what we talked about earlier about the inhalers. If they do home updrafts and you can assist them for, of course, respiratory difficulty, provider prescribed inhaler. There is the common names: albuterol, apropium, metaproterenol, Provenol, Venolin, Atrovent, Alupolent, and Metapril. What's that? So you give that orally, inhalation, assisted with directions that's wrote on the inhaler. Again, for the pediatric. The pediatrics most time has a chamber that goes from the inhaler, and basically that's because it's harder to direct a child to do something, especially when they're worked up. So you get the medication in the chamber, and then they breathe it out of that chamber. It could, yeah, if they have it. Yeah. So Narcan is for an opiate overdose. If you don't know if it's an opiate overdose, you're not going to hurt them if you do give them Narcan. Narcan is something that is covered just by a common layperson. We, think Salem just had an Narcan class here 6-8 months ago. We can give you a contact if you would like your fire departments, for somebody to come speak to you about that. They will give you 2 doses of Narcan, and if you use 1 to 2 doses, you can actually send in a form and they will send you a new box.
So this is, you go to the Criminal Justice Institute, of Arkansas. It's like a 2-hour long computer. You just watch the video on the computer, answer questions, pass it. But fire department wise, every fire department has to get it. The only way, it's like a grant, every time you use it, you send it in, they'll send you a new one, no questions. But
They're doing more and more of those classes. I think one of the churches held one here in the last.
Yeah.
month. So they're trying to get it out there. And
yeah,
expose.
but on the fire department side is everybody on the fire department has to take it. Cause they don't wanna give like 2 people on the fire department take it. Well, everybody on the fire department has access to an Narcan. They want everybody on the fire department access to knows how to use it. That's all bad thing about the criminal justice is everybody want to take it, not just 1 2 people.
So it's gonna come in a little vial. It's gonna have a long prong sticking up at the end of it, and you just shove it up a nostril and you squeeze it. Is all you do. They're not gonna aspirate on it. Again, the nasal is another quick way to get it into your system. Be careful with these patients because they can become combative when you get them out of their stupor. Yeah, so step back once you give it, because they're usually not happy when they come out of it. Yeah. Yeah. So if they don't have respiratory depression, you don't actually like have to give it. But if it's like where they're not breathing adequately, then
If they're still breathing, leave them alone.
yeah.
They're breathing.
Yeah. 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 So this says allergy. I haven't ever seen anybody allergic to it. Every 3 to 5 minutes. So if you've got a patient, the one didn't help, 3 to 5 minutes later, give the second one. EMT approved is IN intranasally, which is the same thing that you guys are going to be doing. So we talked a little bit about the Braslow tape earlier. That's what we use for the child, and that is it. So, any questions? Yep, I believe it.
Sign this.
Thank you all for coming tonight.